Hello, 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 hello. Hello, 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 hello. Hello, 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 hello. Mic check.
Hello, hello. Yeah. Thank you everyone for the patience. We are beginning with the program just in 2 minutes. So please everyone be seated. We are just starting with the program. Thank you.
कह रहे हैं कि बहुत शांत रहना, माइक बहुत दूर से आवाज कैच करता है। देखो शक होगा कुछ हम कर लें स्टार्ट। अब बिल्कुल चुप हो।
A very happy and blissful morning to all of you. I, Dr. Suhani Maheshwari, feel so delighted to be a part of this event. It's a great pleasure and great time to begin with the most eagerly awaited ceremony of every program, that is the inaugural ceremony of 20th ISP PG Convention. On the behalf of entire organizing committee, I extend my heartiest welcome to all the distinguished delegates, teachers, and colleagues to the convention. The Indian Society of Periodontology is dedicatedly establishing new and advanced levels of oral health in the country. This convention aims at providing an opportunity to exchange views on the latest and emerging trends in the field of periodontology. It provides both a platform for all new upcoming researchers and clinicians to share their work and knowledge, as well as they learn through the experienced practical sharings from experts of the field. So, extend your arms and welcome the future. The best is yet to come. To begin with the ceremony, it gives me great pleasure to invite all our esteemed dignitaries to the dais. I would first like to request our dearest scientific chairperson, Dr. Vishakha Grover, to kindly take the seat on the dais. We welcome you, ma'am. It would be a great pleasure to invite pivot of the convention, our convention secretary, Dr. Ashish Jain, on the dais. We welcome you, sir. I would now like to request respected President-elect Dr. Abhay Kolte to take the seat on the dais. We welcome you, sir. Also take the privilege to invite upon dais President of the Society and Chief Guest of the event, Dr. Anirban Chatterjee. Please welcome our Chief Guest with a round of applause. Now, I would like to invite Honorable Secretary of ISP, Dr. Harpreet Singh Grover, sir, to please take the seat on the dais. Welcome, sir. I will invite our organizing chairperson, Dr. Baljit Singh, on the dais. Welcome, sir. And now I want to invite the most dynamic organizing secretary, Dr. Gurprakash Singh Chahal, to kindly have the seat on the dais. We welcome you, sir. Now, to begin with, I would like to request Secretary ISP, Dr. Harpreet Singh Grover, to kindly color the President of the Society, Dr. Anirban Chatterjee. We would now like to take permission from President of the Society, Dr. Anirban Sir, for the start of 20th ISP PG Convention. Thank you, sir. Thank you, sir. We will now seek the blessings of knowledge by Goddess Saraswati. I request our esteemed dignitaries on the dais to kindly light the knowledge. Now, to begin with our 20th ISP PG Convention, I would like to invite upon the stage the organizing chairperson, Dr. Baljit Singh, Professor and Head of Department of Periodontology, Bhojia Dental College. Sir is well known for his humble nature, apart from his huge expertise in the field of periodontology. Sir will now deliver the welcome address to the gathering, and please also introduce the chief guest for the event, our President ISP, Dr. Anirban Chatterjee. We welcome you, sir.
Worthy chief guest for the day, our own Honorable President, Dr. Anirban Chatterjee, President Dr. Honorable Secretary ISP, and our young and dynamic secretary, Dr. Presidents, secretary, executive committee members, ISP, all the life and associate members of Indian Society of Pedontology, trade exhibitors, ladies and gentlemen, good morning to I, on behalf of I am extremely honored and delighted to welcome you to the 20th ISPPG Convention, Chandigarh. Now, you see, you all agree with me that it is very difficult and stressful places, physical forms of the conferences could not happen due to this reason. Thanks to the Almighty, the ease out a bit. The response to this conference is that the press organizing committee is overwhelmed because this convention from the postgraduate students of the different colleges. But I would like to say that we are proud to say that more than 200 colleges from all over the India, they are participating in this conference. And for that, the conference organizing committee conveys the sincerest thanks to all of them for turning out in large numbers. Dear friends, see, it is a matter of, what I would say, a matter of honor for ISP Study Group Chandigarh that, if I'm not wrong, this is probably the fourth major event we people are hosting in the which includes 3 main conferences that we have already hosted. And the credit for this, of course, goes to the very talented member the head office the life for we have seen. In the the data and that will be helpful to all of us, especially the postgraduate students. Wishing you all a great time, Chandigarh. Jai ISP, Jai Hind. Thank you so much. However, another at a personal level, I feel our chief needs knows him very well, but since it is a customer of the function, I'll definitely would like to introduce Dr. Anirban Chatterjee to this August gathering. Sir is former Vice Principal, Professor and Head Department of Periodontics and Implantology, Oxford Anthropology and Hospital, Bangalore. As we all know that he is currently the President of the Indian Society of Periodontology, and under his reign, the Indian Society of Periodontology is making large and big strides. Lot of progress is being noticed by the society under his leadership. Sir has got keen interest in research activities that reflects from the number of publications that he has got in both national and international journals, with citations to the 600s. Sir is the editor of number of journals that include national and international journals. He is past honorary CD Secretary of Indian Dental Association, and along with that, he has also been the past treasurer of the Indian Dental Association conferences. Sir has given more than 120 lectures on different national and international fora. The countries he has given his lectures includes Bangladesh, Nepal, Maldives, Sri Lanka, and Malaysia. And sir has also been awarded with various awards like Bharat Jyoti Award, Best Professor Award, and Best Academician. With this brief introduction to our worthy chief guest, I welcome along with our chief guest all the delegates to the 20th ISPPG convention. Thank you so much. Thank you.
I'd like to call upon Dais President and Dr. Anand for the address.
A very good morning to all present here, and it's a pleasure, and actually it's a real surprise by our conference secretary and thank you, Dr. Ashish, Aljit, and Vishaka. So at the onset, it is very much heartening to see that we are physically meeting after 2.5 years. We have started though with small programs like Parichay, Samiksha, etc., other PEP programs. But in Chandigarh city, which is beautiful, we have come here. So my personal advice to the postgraduate who have assembled here is, I know the city is beautiful, happening. Shimla is not far, but at least spend 2 days of your time here. There are people, intellectual people, periodontists who have given here for you to learn. Learning is a process which goes on and on. And Peri is such a subject which is very volatile in nature. Here, I don't know how many PGs here are by chance or by choice, because I have taken Perio by chance. So last, what happens during whenever you take the PG, it's the only other surgical subject other than oral surgery, or it's a clinical subject, chalo le hi lete hain Perio. But once you are in Perio, you understand the depth of Perio, because it's the keystone of dentistry. It is the epicenter of dentistry is Perio. Without Perio, I think none. I'm not trying to tell that we are the only one, but without proper healthcare, with gum care, we cannot have a proper healthcare. That is known and it has been proved. Because of that, WHO itself has come out with a resolution by 2030. They want to have complete eradication of gum care. And since gingivitis, they want to eradicate by 2030. They have come up with the WHO has come up with the resolution, because now what has come up is that we are into it, that systemic diseases are very much related to gum disease. Okay. Now, even the new terminology has come from periodontal medicine, gender medicine, because we see more periodontists, I mean, PG students who will be a future budding periodontists are women. Now, the women gender medicine has come, which are more prone, women are more prone for 6 diseases: Alzheimer's, diabetes, cancer related to periodontitis, okay, cardiac disease. They are more prone. So, Perio is a subject which is like Devanand evergreen. It's evergreen subject. So, I'm as a when I took over president, I had in first and second row, and we have, it is very much heartening to tell that World Oral Health Day for 20th colleges have participated all over India. World Oral Health Day, brainchild of our conference secretary Dr. Ashish Jain, and it has been taken. There was Rangoli competition, there were skits, there was dramas, there was lectures, and etc. etc. So it is something which always Perio has been in the forefront. If you, why you are saying keystone of dentistry is Perio? Because even in any scientific program, we start, other subjects follow us. Okay, so that's the importance of Perio in our society. So let's begin and let it be a very successful. Already, it's a successful PG convention, 20th PG ISPG convention, and I'd like to congratulate our conference secretary, Dr. Ashish Jain, Vishal Grover, scientific chairman, Baljit Singh, organizing chairman, and our dynamic GPS. I always call him GPS because anywhere he is there. तो बस हर जगह में मिलते हैं हम. Very very dynamic GPS. बस बोलना मुंह से पहले आ जाता है. I'm with his guys. We are going much forward with friends. Then we have a Peter Saab, wonderful journal. He has bring ISP journal just to new heights. Then treasurer all the खजांची तो है ही हमारे. Time. So all our fellow colleagues on 20th Congratulations. Thank you. Jai ISP, Jai Hind.
Thank you so much, sir. It was indeed a pleasure to kindly present the token of appreciation to President of the Society. Please, everyone, give a huge round of applause. Dr. Ashish Jain is currently working as the principal of Dental Institute, RIMS, Ranchi. Sir is the editor of Bible of Periodontology, that is, Second South Asian edition of Carranza Clinical Periodontology. I now request our convention secretary, Dr. Ashish Jain, to kindly deliver his address.
A very good afternoon to all of you. Honorable members of the head office, the president, sir, president-elect and secretary, sir, on the dais, my organizing team, EC members of ISP, life members, office bearers, past president, and most importantly, dear students. Before we get into the conference and the other things attached to it, it really gives me a lot of pleasure to say, for reasons whatsoever, to actually make a number of participants, in terms of also in terms of what we have. And all this that everybody reaching it. And you have been hearing one name over, and that name surely deserves a mention. Organizing a PG convention at a time when the world has just opened up was a real difficult task. And believe you me, all this was essentially taken care of by one man. So if you will, I can actually say that this is a one-man show. And that one-man show is nobody else but our organizing secretary, Dr. Gurprakash Chahal. So certainly a much bigger round of applause for him, please. So as others also said, because the response we had, because of the quality we wanted to give you in terms of scientific deliberations, we extended our PG convention from 2 days to 3 days so that we could wrap up a lot of our papers and presentations on the first day, which was yesterday, so that, you can have chance to sit here who wants to sit or go to Shimla who wants to go to Shimla, whichever way. But, I'm glad that people are here, and as the day will progress, the hot seats will get certainly filled up because we have the choicest of the brains from ISP and elsewhere to talk to you. We were in your chairs, okay, people like us were long back but some of people sitting here were in your chairs not that long back. And we understand the value of having missed those deliberations at our time, because we also wanted to go to Shimla. But now we realize that was a time waste. So stick back, stay back. I can assure you, you will go back very enriched. You'll go back very satiated. Shimla, you can come another time. Okay? And we have we have a very apt design panel discussion later. We have today Dr. Ashish Kumar, the editor, the class auditor, of our time. We have Dr. Dan. You need to listen to him. And others also. So we have Dr. Vishakha coming in with cutting edge research programs. So please stay back. That's why you are here. Stay back. Wonderful trade fair. Please visit there as well. We understand the temperatures are a little unfriendly. It gives you freedom to sit inside the hall again, but that's beyond our control. We can't really do anything about the temperatures outside. There may be few glitches here and there. Those glitches are essentially because probably we did not give Guru Prakash Chahal as free hand as we should have been. But whatever points, whatever events you feel were well organized during these 3 days, again, I reiterate, it's only because of a singular effort, which is Dr. Chahal. Along with that, we have our organizing chairman who did a great job, Dr. Vishakha, the scientific chairman, her team so they're so dedicated, they're not even here, of Dr. Nandini, who's looking after posters, Dr. Jyoti, who's looking after posters, Dr. Baljit and his team at Babu, who's looking after papers. And we have Dr. Rose from Punjab University, who's looking after master classes. Again, master classes is a concept, and you'll be surprised how all master classes are filled up on the 4th of launch. I mean, that was the excitement in you. And besides them, many more. I'm sorry if I'm missing out on any. Dr. Nymphia, her team are at DAV Yamnagar. So thank you very much. Thank you all for coming, and a sincere appeal to enjoy your stay here, but alongside stay back in the hall also to go back a little more learned. Thank you very much. Thanks.
Thank you so much, sir, for your inspiring talk. Now, I would like to request First Vice President of our society, Dr. Manish Khatri, Professor and Head, Department of Periodontology, IDST Modi Nagar, to kindly introduce amongst all of us the President-elect, Dr. Abhay Kolte.
Thank you, Dr. Sohani. Respected dignitaries on the dais, off the dais, ISP head office members, EC members, ISP life members, and ISP associate members. A very good morning to you all. As the Vice President of the Society, I would like to welcome you all to the city beautiful Chandigarh for the 20th ISP National PG Convention. Congratulations to the organizing team, Dr. Jain, Dr. Baljit, Dr. Vishakha, and Dr. Chahal for organizing such a beautiful PG convention. I'm thankful to the organizing team for giving me an opportunity to introduce a dynamic personality, Dr. Abhay Kolte. Dr. Kolte is one of the most active ISPN and has worked tirelessly for the upliftment of our branch as a specialty. His innovative ideas are always welcomed by the ISP head office. Sir is a recognized PG and PhD teacher by MUHS Nasik and has a teaching experience of over 25 years and is presently the professor and head
Department of Odontology, VSPM Dental College and Research Center, Nagpur. He is also a member of the Board of Studies and a speaker at various national and international conferences and journals. Of the Indian Dental Association and ISOI and has worked on society. He is currently the president-elect of the Indian Society of Periodontology. I'm grateful to sir for being the guest of honor for today's inauguration ceremony. Over to you, sir.
Dignitaries on the dais, Chief Guest and President of Indian Society of Periodontology Head Office, Dr. Anirban Chatterjee, Secretary, Dr. H.S. Grover, sir, Chairman Organizing, Dr. Baljit Singh, Organizing Secretary, Dr. Gur Prakash, Scientific Chairperson, Dr. Vishakha Grover, and the backbone of this 20th ISP PG Convention, Dr. Ashish Jain, the Conference Convention Secretary, dignitaries of the dais, past presidents of ISP, senior members, my colleagues, and dear friends. Well, I will not take much of your time because we are behind schedule, and just a bit of advice for the young and budding periodontist. The organizing committee has made great efforts in bringing all of you together for the scientific feast. And as you know, learning is a journey and not a destination. So please, my sincere appeal to all of you, please upgrade yourself. Please be in the scientific halls and learn the newer skills, newer techniques in our science of periodontology. And my best wishes for a successful convention. Thank you.
Thank you, sir. It was really nice listening to you. Now, I request the organizing secretary, Dr. Gur Prakash Singh Chahal, to kindly offer appreciation. A huge round of applause. And now, with all the zeal, I would like to request the scientific chairperson, Dr. Vishakha Grover, who is the Joint Secretary of ISP and Associate Professor at Department of Periodontology, Dr. Harvansh Singh Judge, Institute of Dental Sciences and Hospital, Punjab University, to kindly deliver the the address to the gathering.
Thank you, Suhani. A very good morning to all present, respected chief guest of the ceremony, our very own President ISP, Dr. Anirban, Secretary ISP, Dr. H.S. Grover, distinguished members from the ISP family, on the dais and on the dais, all guests, colleagues, and dear delegates. Indeed, it's my pleasure to be here with you in this moment at 20th ISPPG convention, and my heartfelt welcome to all of you to this city. Honestly, I just need to submit, it's such a pleasure to see such huge participants coming from across country. Registration not chaotic, but really because That is where we certainly appreciate your high level of interest to the subject and the event. So pleasure to have you all here. And on the same note, we have sorted masters for you who have their highest expertise in their respective areas, who will be talking some priority areas for the postgraduates present here. Apart from that, there's only one thing I would like to mention. Scientific meetings usually, sometimes they are distanced from the action, the way the lessons and skills taken home. So let's make a commitment to make it different. Whatever you learn here, take it home, take it to your practice. You have a chance to interact with all the mentors all the time. You must have discussed your posters and papers with the chairperson and judges. There is a wonderful program ahead for next 2 days, thanks to the diligent scientific team, collaborating colleges and co-sponsoring agencies who have made this program truly a worthwhile program in the spirit and mandate of ISPPG convention. So I am sure that you are going to have a very productive, stimulating time ahead. Take this time to discuss in between you, share your experiences, foster new ideas for research, for future research. And I really wish you a very productive conference and enjoyable stay at Chandigarh. Thank you.
Thank you, ma'am, for your inspiring words always. I will now request Secretary ISP, Dr. Harpreet Singh Grover, to kindly provide the report of activities.
Very good morning, President Dr. Anirban, President-elect Dr. Kote sir, the who's age, senior society who are there in the front rows, and delegates. We have gathered here to celebrate a physical convention after almost 2 years, and as rightly pointed out by the organizers, it has been a huge success in terms of numbers. To present a brief report of the ISP activities, this year started all our physical in full steam. In span of months, we have been able to conduct 4 colloquiums, which were conducted at Bhubaneswar, Chandigarh, Gurugram, and Indore. They were all done in the month of February. Then in March, we had our flagship programs, Samiksha and Pariche. They were hosted by Bareilly. We hosted a Pariche. Then we hosted a Pariche in Mahe, and we hosted a Pariche in Gujarat, Visnagar. We had one more program in Gujarat, which was in Jamnagar, Samiksha, and we had a wonderful Samiksha carried out at Yamunanagar. In between, 2 huge ISP study group events were conducted. One by ISP study group Johar, which had a presence of almost 300 delegates in a PEP, and another one in collaboration with Terna Dental College, Perio Vista, the ISP Mumbai study group. So study groups have been our, backbones, and today's program is also the effort of ISP study group. So with these programs, we had the World Diabetic Day program, which was started in the last year in November, but it carried on through all these months. And as President Sir has told, a hugely successful program which was conducted on the occasion of World Oral Health Day. And many colleges to the tune of almost 180 colleges participated. So it is one thing to conduct the programs. It is another thing to create a splash about it. And ISP has been very fortunate to have a president who is very, very media savvy, especially social media savvy. And we have been able to make a big splash all over, thanks to sir's, absolute fast postings of all these event photographs, pictures, and I have been congratulated by my colleagues in sir, you really are making great waves in the virtual world. So the rest of the programs, of course, will be coming over a period of time. We will have integrates, 3 integrates, which have already been allotted. That will happen in the month of August. And of course, other, programs, some guidelines, ISP guidelines, which we have been doing. Further addition to those would be done. And for all that, I need to thank the office bearers, the EC members, and all the support which we have received from time to time from all the life members. Now, we as a society are now, 47 years young. So in 3 years, we'll be membership has been our backbone, and I urge you all to, fulfill your membership duty towards our society so that our family becomes big and strong. We are already above 2,500 or so in terms of number. So with these words, I thank you all for your patient listening. Jai Hind.
Thank you so much, sir. I request the organizing secretary, Dr. Gurprakash Singh Chahal, to kindly present the token of appreciation to Dr. Harpreet Singh Grover. Thank you, sir. And now it's time to call upon the organizing secretary, Dr. Gurprakash Sir, Assistant Professor at Department of Periodontology, Dr. Harvansh Singh Judge, Institute of Dental Sciences and University, who has been working interminably for this event. Sir, please deliver your kind address.
First of all, I am overwhelmed what has been said about me. I believe I am given more credit than what I deserve. And I may be just a face. It's our entire organizing team, which has been working round the clock to make this 20th ISPPG convention a success. Now, on the behalf of my privilege to welcome you all this event. This inauguration is special for all of us as we are meeting physically for an ISP flagship event after a span of almost 2 years. It is heartening to see the enthusiasm which has been shown by our delegates who have come from across the country for this event. We welcome you all to the City Beautiful. We are thankful to the ISP head office for this opportunity to host this event and their unwavering and unflinching support. We welcome all the dignitaries on the dais and off the dais, the organizing team, and which has been working tirelessly to make this event a memorable one for one and all. Our scientific stewardship, the scientific chairperson have put lots of efforts to have some of the best minds in the periodontology in our country here for the science deliberations. Dr. Tarun Nanda, Dr. Tanvi Ori, Dr. Kanika Agarwal, who have been looking after all the paper presentations, Dr. Nandini Bhaskar, Dr. Jyoti and their team who have worked zealously after post-present to have an immaculately planned schedule. Dr. Rose Kamaljeet Kaur, who has arranged the master classes very meticulously, selecting, organizing the topics of interest for our delegates. And above all, our organizing chairman, Dr. Baljit Singh, for placing so much faith in me. Our whole team has been working very hard for this event. We are especially thankful to the ISP head office for Dr. Ashish Jain, our convention secretary, who despite so many personal and professional commitments has been there to guide us, help us at each and every step in the run-up to this event. We are also thankful to our sponsors who have shown immense enthusiasm to be part of this event. And I would also like to express our gratitude to all our esteemed speakers who have been more than eager to share their knowledge and skills with our delegates. And I would also say the shortcomings, if any, in this event are mine. I would end by saying an investment in knowledge it always pays the best of interests. So all our budding periodontists, please imbibe as much as you can. Hope you all have a great time and a grand time. Thank you. Jai Hind.
Thank you so much, sir, for being so humble yet energetic. Now, I request everyone to please stand up for the national anthem. Thank you, everyone. As we all know, knowledge has a beginning but no end. So after the inauguration, go to the extra knowledgeful scientific sessions with all the speakers we have with us. So I would like to call upon Dais, Dr. Shania, Dr. Vandana from DAV Yamuna Nagar to quickly take up the dais, and we'll be resuming with the scientific sessions after 5 minutes.
इधर करो। हाँ, क्या करें?
Moving forward to today's scientific session, the 2017 classification proposed by AAP and EFP together created a buzz around the world in the field of pedontology. A lot of articles have been published which are of critical in the new classification. The current session therefore entails the deep insight to the following topic, merits and demerits of the classification of periodontal disease. To begin with this session, I would like to call upon stage our very first chairperson of the session, Dr. Nimfia Pandit ma'am. She is presently working as a professor and head in the Department of Periodontics, DAV Dental College, Yamunanagar. From SCB Medical College, Cuttack in 1993 and completed her MDS in Periodontics in 1998 from Government Dental College, Ahmedabad. She is immediate past president of Indian Society of Pedontology and in the editorial board of the Journal of ISP and many other national journals. I welcome you, ma'am. The next chairperson I would like to call is Dr. Manish Khatri, sir. He currently heads the Department of Periodontics, IDST Modi Nagar. He is gold medalist graduate from Maulana Azad Dental Sciences, Institute of Dental Sciences, Delhi, and he did his masters in periodontics from College of Dental Sciences, Davangere in 2001. He is the vice president of Indian Society of Periodontology, and he has been the executive member of Indian Society of Periodontology for 4 terms. I welcome you, sir. I would kindly request the chairperson to introduce the speaker of the session, Dr. Ashish Kumar, sir.
Hello. Hello, am I audible? A very good morning to all of you. Welcome to the first session, scientific session. It's a pleasure for me to introduce Dr. Ashish Kumar. He has given every time we ask for his CV, he says, don't say anything for my CV. So whatever I am reading is just 0.1% of what he is. He's an amazing person, a very good orator, and I don't know what to say. He has, I think, so much experience of perio that it's impossible for anybody to copy. So he is currently working as a professor and head Department of Periodontology at Dental College, Regional Institute of Medical Sciences in Fal, Manipur, India. He is the alumnus of Bapuji Dental College and Hospital, Davangere. He's had numerous national and international publications to his credit. He has introduced one recession, this classification, and made very amendments to many of the classifications.
Thank you. Introduction, ma'am. Can we have the lights off? Off. Presentation with my mother and hospital Davangere, boss, my guy was recently big Shraddhanjali to and in Perio whatever I have to this man. Thank you so much, Ashish Jain sir, Baljit sir, Vishakha, GP, for having invited me to this City Beautiful and given this opportunity to speak here on this topic. I work in Dental College, Regional Institute of Medical Sciences, Imphal. Imphal is the capital of Manipur, northeast of India, near the Burma border. And these are my dear who work with me in my department. So the topic for today is merits and demerits of the new periodontal classification. The topic is very wide and I'm going to concentrate and limit myself to only the important aspects of related to health, gingivitis and periodontitis, which we generally deal with regards to merits and demerits, not going to details of other parts of this classification. Now, the classification basically is a systematic arrangement of similar entities on the basis of certain differing characteristics. Now, this classification had a world workshop held in Chicago in 2017, and finally, this classification was proposed in Amsterdam, not the right place to propose the classification at least, but in 2018, and this classification was formed on the basis that they had 4 groups, 4 aspects. Just to explain how this classification had, for example, group was given to few people in that the topics were divided and few people were given topics to work on those topics. And finally, all those people who were working on those topics, for example, if we take a work group 1, they had health, gingivitis, non-plaque-induced gingivitis and case definitions. So at the end, all these people and additional people were all together and they created a consensus document. So when you go through this 326-page classification document, you will realize that certain things which are given in the chapter of health would have changed in the consensus document because what was proposed by those people who worked on health was accepted and it was changed. So you might find difference. So finally, it was the consensus document which is valid and which was, created. And this was the 4 work groups. First was the health group, the second was periodontitis, the other conditions and the conditions, which is the new classification as we all know of. Now, let us start with the there was new evidence which was coming into play and which they were looking at. The new evidence of microbial disc biases which was coming into play, where it was being seen that pathogenic biofilm was important but was not itself insufficient to cause disease. Then the response of the body, which was supposed to cause almost 80% of destruction, and having a disease classification which could give you an individualized diagnosis, which was, they were planning to have in this classification. So the evidence, what they were looking at, there was an article which was published in JCP, wherein they were trying to compare the phenotype of gingivitis to the biology, what was happening behind it. Now, in this study of 21 days, they had one side which was, they were maintaining oral hygiene properly, and the other side was not being maintained, and they were given a stent, and the oral hygiene maintenance was stopped. Now, what they were seeing in this was, as on the side, the dotted line shows the normal side, the solid line shows the side where oral hygiene was stopped. And as inflammation started, they saw that PI, NGI, and bleeding index all increased as the inflammation started. Now, this was the phenotypic changes which were seen in these cases. Now, at the end of biological side, they saw that if you see this, the GCF volume, now GCF volume was increasing, and the GCF volume increases as the phenotypic changes are increasing. Now, what they saw was, as the GCF volume was increasing, even all these substance P, cathepsin C, interleukin 1 beta was also increasing. Now, this was the amount with GCF, this was increasing. But another thing which they noted was, okay, now another thing which they noted was not only the amount with GCF, these biomarkers increasing, but the concentration of these biomarkers were increasing. That means the rate of these biomarkers in GCF was increasing faster than the amount, thereby meaning that the substance P, cathepsin G, interleukin 1 beta was increasing fast, the amount was increasing, the concentration was increasing in the GCF, whereas elastase and alpha-1 see the faster before the what it meant that the phenotype later happening later to the biological change. That is, biological changes were before the phenotypic changes. What they did was proposed a new model of stages from health to gingivitis, where they said that from health to when it starts to gingivitis, the neuropeptide P is the substance P is the first biomarker between a health gingivitis and on later stages, if she and in the last stage, the formulation starts, these last biomarkers will start. In this model, speed feature disease. Now, the important aspect in this was that there was a biological model which was compatible with the phenotypic model of the gingivitis. That means what is happening, the phenotypic. Now, the conclusion was that the biological and clinical phenotypes could be the question model, similar model where the biology or what was happening in the tissues could be related to the phenotype of periodontitis. So in that case, what they did was, so what they did, it was seen that this cannot be done for periodontitis because it is too complex. Now, there was a study which is called as transcriptome studies. The transcriptome studies are the studies of the RNA which are produced in relation, from the tissues in relation to maybe, disease, environment, and also the transcriptomes is the study of those RNAs which are produced, and this is the RNAs are very short-lived. So what they did was, in one of the studies, not worry. So there is a study where they took two group of patients which were very clearly distinguished into chronic periodontitis patients and aggressive periodontitis patients, and they took the RNAs of these patients and studied. And what they were expecting was that when transcriptome studies were done on these patients, the RNAs would also get divided as per aggressive and chronic periodontitis. But to their amazing fact, what they found was this was what happened, but it did not divide, the RNAs did not divide as per the classification of the patients which they had taken, that is chronic periodontitis and aggressive periodontitis. But the present antibody response. So that the phenotype of chronic aggressive periodontitis and allergic phenotype so that we following chronic don't have any basis. So the third thing which they look had the new model of periodontal pathogenesis which was introduced after 1999 classification. The 1970s model was very easy, and it was this how it was in the 1997 Conman pathogenesis said microbial host modulation, host response got into it, and then finally you had the symbiosis and dysbiosis coming into play after 2013-14. Now symbiosis basically meant that you had a small amount of bacteria, and in response to that bacteria, the host response was also small and normal, which could maintain the tissues in health. Is basically a symbiotic relationship which exists between microorganisms and host response. That is, the amount of proteins and peptides which are released by these bacteria result in a host response that is proportionate and resolving. Now, this is important to know. Now, here they said that low biomass or low amount of microorganisms present is very normal. And when it goes to gingivitis, they said that it is incipient dysbiosis, that is a person where the microbiome in number and that is in quantity and quality starts changing. And if the person is not susceptible, it will not go beyond gingivitis. And periodontitis only occurs when this composition and the number of microbes changes. Now, what was important here to note is that from 70s to 80s, where was considered to be absolute absence of microorganism, it had gone to a state where it was considered to be a low biomass, which is considered to be normal. So there was a distinct change in thought process here, wherein a low biomass was considered to be pretty normal and not considered to be a disease process. So the third important advantage of this classification was this classification gave a clear-cut clinical case definition of every disease. Now, when you study epidemiology, you would find that some of the studies have taken, 2 sites, 3 sites of gingivitis. In periodontitis studies, you would find 1 mm, 2 mm, 3 mm. So there is no definition what is periodontitis or what is the threshold of periodontitis which should be taken. So here what they said was, they gave a case definition. Now, case definition is basically how you would differentiate between different individuals on the basis of symptom and prognosis. Now, this helps in classification. No classification possible having a case definition. Then classify help you in treating that patient individually. For example, of more than 10% big size is gingivitis. So put it in a gingivitis patient as per classification, the diagnosis is gingivitis, and you will treat this patient individually on the basis of this diagnosis. So this was one new step which clearly defined the case definition, every group has specific case definition of was clearly defined to know how you have the next advantage aspect of clearly defines what is called and gingival health. Now, till why was this definition required? You wanted the definition because you want a preventive starting point. You want to define whether a person requires any treatment or not, and you also want a therapeutic endpoint that after treatment, what stage would you say that he has reached that particular point that he does not require any further help. So a therapeutic endpoint was also required. So you wanted the definition of periodontal health. So they're looking at what is periodontal health, how could you define it quantitatively, is pristine health possible or not, or is it seen in people or not. So the health definition, what they first took was the WHO health definition, and they tried to define it on the basis of same definition, but the definition which was being formed on the basis of health definition was very difficult and difficult to quantify. So they had to simplify this definition. So what they were looking at now to define it was, as I said, during 1970s and 80s, pristine health was considered to be absolutely absence of microorganisms. But now question what they're looking at is, does this exist in normal population? Now existence in normal population means, does it exist in 95% of people or population? Because as per medicine, if it exists in 95% of people, that is called as normal. So the question was, does pristine health, which has been defined, exist in 95% of population? So it was seen that 95% of people or adults had 1 or 2 bleeding points. So what they said was, that means we have to accept that pristine health is not possible, and presence of 1 or 2 bleeding points in any individual at any stage should be considered as normal, and absolute absence of microorganisms is just not possible, and a pristine health, and you need to accept that health is a situation where some localized sites of inflammation would be present, and it is still called as clinically healthy means a state which are present and called as healthy. So the biology behind it, the new pathogenesis is that it's homeostasis. Back to 1970, find that homeostasis was considered as GI and PI and absolutely no infiltrate. But now it's considered as small amount of infiltrate which is present and which is considered to be normal. Okay, now earlier presence was considered to be disease, but now presence of PMN was considered to be surveillance. That is, it is a physical presence of PMN and issue in a normal way in presence of small amount microorganisms. So that way, became a state of clinical health wherein the response of body maintains is such that it is a small amount and maintains the tissue in health. Now, next question was, can health and site of inflammation stay together or can they appear together? So if you see in this photograph, slight amount of grazing in lower anteriors, slight amount of inflammation, but rest everything is normal. So this is a case of gingival health with the site of inflammation, but not called as gingivitis. So this is how they defined this as a state of clinical health. Now, the next question was, biologically we said that some small amount of infiltrate has to be present, but what is the clinical diagnosis of this health? So clinically it has to be the markers, the GCF or the BOP, which has to be limited or minimal to say that it is healthy. So what they decided, they said indicator of periodontal health is only bleeding on probing. So here for first time they decided if you have to diagnose gingivitis, so the means that absence of bleeding, the disease 100% not to be a parameter which we use to define health. Alone just cannot be used to define, they have to be seen in conjunction with BOP. Alone cannot be used to define whether it is a case of gingivitis or periodontitis. So the next question they decided is, where would you elicit bleeding from? Now when we were studying, we were told that bleeding has to be elicited from the sulcus lining, because the sulcus lining becomes thick when you probe, it will injure the blood vessel and the bleeding will start. Now here they deliberated on this question that whether you should elicit bleeding from the lining or whether you should elicit bleeding from the base of the pocket. Now there was, which is better method, there was no consensus, there are no studies, they could not say, but they said something which was very important. They said that preferred method is from the base of the sulcus, because we are trained in our colleges to probe the base of the pocket, not to feel the gingival sulcus epithelium. Secondly, when you probe the base of the sulcus for BOP, simultaneously you can see the probing depth, simultaneously you can see the clinical attachment loss, which is not possible if you elicit bleeding from the sulcular epithelium. Thirdly, bleeding, as it says, self-reported patients generally come to you with complaint of bleeding. So this is a bleeding which is self-reported and can help in diagnosing, and the patients can also come to know. So that's why bleeding on probing from base of the sulcus is considered to be a mechanism which you should use to diagnose a case of health. Now, next question is, what probe should you use? Manual, automated, Florida probe, whatever different probes are used. They saw different studies and then they concluded that the manual probe still remains the best, and that is the probe of choice till date to diagnose any case of health or gingivitis or periodontal disease. The automated probes still are not advocated, although of things, but probe remains the of choice to diagnose. Now the question was, periodontally healthy, they have said that this is amount of inflammation is periodontal. Now they went on to define healthy anatomically periodontium. What this minimal inflammation and intact term is also periodontally healthy, and in cases of reduced also healthy. So they classify it as clinical health on intact periodontium and on reduced periodontium. In reduced periodontium, there are two categories. One which was treated for periodontitis is now healthy. So they called it a stable periodontitis patient. And second was non-periodontitis patients, which means that the difference between stable and non-periodontitis patient was stable periodontitis patients had periodontitis at one stage and could have periodontitis later on. So they were at risk of further attachment loss. Whereas non-periodontitis patients, for example, patients of gingival recession, who have recession because of excessive brush trauma. They don't have periodontitis, but they have recession. So such patients are non-periodontitis patients, have clinical attachment loss, but they are not at risk of further attachment loss. So this is how health was decided, discussed and cleared for everyone to use in this classification, and this was the big advantage. And this is how they said, any case where less than 10% of sites bleed was called as health. In the case of non-periodontitis patient, also the pocket depth is less than 3 mm, less than 10%, and attachment, because it is a reduced periodontium, bone loss may be seen on radiograph. This is how it is healthy. So in all these three cases, if you would see that after treatment, they have said less than 4 mm, because if you try to, what they said was, if after treatment of periodontal disease, if you try to achieve a pocket depth of 3 mm, it many times results in over treatment. So they said less than 4 mm, non-bleeding, and less than 10% of sites after treatment can be called as a health in a stable patient. The next thing was the changes which were done in gingivitis biofilm induced. Now, first thing what they did was they removed these three categories: menstrual cycle, gingivitis, oral contraceptive, and because they are not seen nowadays, very rarely seen, so they were all removed. Now, basically, they divided it into with biofilm and with which are mediated. In mediated, they had two categories: modifying factors and predisposing factors. Now, predisposing factors are the local factors which were present, and this is how they finally divided plaque-induced gingivitis. Here again, they clarified what you can use to define gingivitis. Use, gingival index, we use color changes. So what they clearly said was color, GCF volume, gingival index, GCF proteins, your biomarkers, CRP, genetic markers are all unfit to decide gingivitis. The only thing which you can use to again define gingivitis is the bleeding on probing. Now, advantage is that, as you know, it is the first sign, objective sign, patient sees it, and histologic validation that more the inflammation, more the bleeding, less the inflammation, less the bleeding, histologic validation is there. And as it said, it gives you the site-specific information. If it is bleeding at one place, it is, chances are that it is inflamed. If it is not bleeding, as I said, the negative predictive value is 100%. Not bleeding means it is not diseased in that area. So a site-specific information which you get from bleeding on probing, an easiest method to define a case of gingival inflammation. So here was very important. Again, now they said that health was less than 10%. Any bleeding site more than 10% was defined as gingivitis. Now, if you see that in case of stable periodontitis, they have not called this as gingivitis. They've called it as gingival inflammation. Why? Because now, as per new classification, once a patient of periodontitis is always a patient of periodontitis. So once patient has periodontitis, he cannot have gingivitis. So they said that if after treatment the patient is getting inflammation, that has to be called as a case of gingival inflammation in a stable patient. You cannot call it as gingivitis because he has already been diagnosed as a case of periodontitis. So now, more than 10% to 30% was localized gingivitis, more than 30% sites bleeding was called as generalized gingivitis, and less than 10% was called as clinical health. The concept here was that minimum level of gingival inflammation to the dentition, which is less than 10%, can be considered as the indication of this condition. All clearly said that gingivitis is a clinical diagnosis. None of these things, microbiological, molecular, pathophysiological, or any radiograph can be used to diagnose gingivitis because the evidence is not clear to define. Any of these two cannot be used to define of these features. Also, what they clarified is that this 10 to 30% and less than 10% is to define the extent. You cannot use it to define it as mild, moderate, and severe. It is just defines the extent, not the severity. You just cannot define it as mild, moderate, and severe. So diagnosis has to be the extent. It is localized or gingivitis, not mild, moderate, and severe. So after this chapter, there was a clear-cut distinction that pristine health does not exist. Then you have a clinical health and you have a gingivitis case on basis of the BOP markings or percentage which we have just discussed. The second change, important change, was seeing in the group of periodontitis. Now, here for first time they had a clear-cut definition of periodontitis, that is more than 2 mm of cal in interdental areas, in non-adjacent teeth, or 3 mm of cal on the buccal or the oral lesion. So earlier they had defined periodontitis as loss of clinical attachment, but was not defined. So here quantitatively for first time periodontitis was defined. Then the most talked about thing which we came into was, the grading and staging, which was based on the staging grading of cancer. Now, this is how they had, stage 1 to 4 and grading ABCN, how it was determined. And this is how they defined the periodontitis in new classification. Now, the staging was about, the severity and extent of disease. Now, if you realize this, that in earlier classification also, we were using severity and extent. We were defining it as generalized chronic periodontitis, severe, mild, moderate, everything we were defining. But the thing which was new here was the complexity factor which had been introduced in this classification. Now, complexity meant that they are talking about the effects of kind of alveolar, which are bites and all complexity factor which was added to the classification. And as I said, the severity and extent was already present in the earlier classification also. Then about the progression of disease, how the disease has been progressing in an individual, and it also, had modifiers about smoking and diabetes which were added to it to add one more dimension to the classification. One important point which they added was, once you have given a stage, and if you treat that and the stage, you cannot downgrade the stage. If suppose you have called it a stage 3 and you have treated the patient, have reduced, intramural defect has, resolved, still it will remain a patient of stage 3 only, because they want that you should concentrate on the maintenance of that patient as a stage 3 patient for lifelong. So it was said that if in a periodontally healthy, a patient gets gingivitis, you treat it, it will get back to state of health. But in a case of periodontitis, it will become a reduced periodontium post-treatment case and a periodontitis patient for life. It will never get back to a normal case as per the new classification. Now, what was the advantage of this staging? What they said. First advantage was that you were moving from a unilateral diagnosis or a diagnosis which was unidimensional based on past extraction. Earlier, the diagnosis you would write is as generalized periodontitis, but now your diagnosis is based on where you would, when you have the loss kind are present, what is the kind of bone loss which is present, how many teeth have been lost. So all those things will be there. So from a standard diagnosis of generalized chronic periodontitis, which you would give in case which has got attachment loss, you will give the same diagnosis in the cases of which has got 6 differentiated. The second advantage was that staging could be defined at these points. Today, maybe he has stage 2. It does not take. So you will have a specific diagnosis for that time, for that moment. You have time to treat diagnosis for that particular time. It helps in communication and tells someone, once you communicate, suppose I tell someone he has a generalized chronic periodontitis, you will not come to know what to be done. When you have a diagnosis, will know from stage 3 that more than, around 4 teeth would have been lost. The pocket depth is more than 4 mm. You will have intrabony defects of 3 mm. So this diagnosis clearly tells you and the stage and prognosis which is required. So this diagnosis helps in deciding the prognosis of the patient. And finally, a standard severity and extent has, as I said, is always there, but complexity helps you in giving a personalized diagnosis for that particular patient. For others, every time, as I said, the diagnosis would be same, generalized chronic periodontitis. But here you have a personalized diagnosis for every patient at different stages of his disease. So this was the advantage of having stage of disease. And the last advantage was this, the first time implants becoming a big part of your periodontal studies. This classification has been added for first time in the classification of periodontal disease. So this was one advantage. Now coming on to the demerits of this classification, you had these many classifications, and the first thing what they said now in the new classification was that it has been reduced only to 4. Now, as you know, when any of these, you always have conditions apply. You have small star. So don't go by what is visible. Now I'll show you something. This is how plaque-induced gingival sub-classification. I cannot read because I could not where I could put in one. It is not easy. Overall, you only 4 categories, but see the new subcategories which you need to remember. Abscesses at gingival periodontal abscess, only 3 abscesses, but now there is no pericorneal abscess. There is no term which is called as gingival abscess. It is only periodontal abscess in a periodontitis patient, in a non-periodontitis patient, and you will have to look for factors whether the periodontitis, the periodontal abscess is because of impaction, orthodontic forces, harmful habits. So you have so many sub-classifications which you will have to look into before you diagnose the case. Necrotizing periodontal only, you had to, now you see how many in adults, in children, you have to see for predisposing factors and then say. So the number of classifications again makes it difficult. Now see, perioendo, you had 3 sub-classifications. Now you see root fracture and you see the other sub-classification, one grade, pretty narrow, very subjective classifications which are given now, and you will know the sub-classification of endo and perio. Earlier, it was very easy, primary endo, primary perio, or a combined lesion. Manifestation of systemic disease, only these diseases. Now you see it is divided into 3 main parts: influencing periodontal inflammation, influencing pathogenesis, and having periodontitis independent of the systemic disease. And if you see the classification of this 1.1, 1.1.1, 1.1.2. So first has so many sub-classifications, 2 has these classifications, 3 has so many classifications, and is mentioned, define, read and learn for a clear-cut definition to define and classify it. The next disadvantage, all these people are great people who devised this classification. The disadvantage was they were all academicians. None of them had a private practitioner who could give them a practical idea of how difficult it would be to adapt this to a practical application. So this was the problem with this classification. Then this is my take. Periodontal health, they could have very nicely defined, but there was no need to put it in class. They could have clearly defined anything less than 10%, and they could have removed it from classification of diseases. They could have defined it. There was no need to define it in the classification, disease system. Then you see it is a case of periodontitis. Here they say necrotizing periodontal diseases. Now necrotizing periodontal disease is a group of diseases which also includes gingivitis. Now they put this as under a case of periodontitis, also including gingivitis. Then the main heading is periodontitis. Another group is also periodontitis. Now here in the book they say that the remaining clinical cases of periodontitis which do not have the characteristics of necrotizing periodontitis or systemic periodontitis should be diagnosed as periodontitis. So do they mean that first you have to rule out necrotizing and systemic diseases, then only you can diagnose them case of periodontitis. Now, localized the litter war which started. Okay, now the unique feature of localized aggressive periodontitis, the age of and the age of is very unique to localized aggressive. Now, there was a letter written by Dr. Fine, Dr. Armitage. Now, Dr. Armitage was also a part of this group of 2017 studies. Wrote a letter say that this classification of staging in a case with, they showed this radiograph where they said that the same, the upper one radiograph of a 51-year-old patient and lower one of 19-year-old patient, they both will be classified as stage 3 and grade C. How do you differentiate? But different radiographic features and they have different the same in this classification, and that's not right. Now, replied by the people who had written this periodontitis classification, where they said that yes, that LAP is different and has a different phenotype, but they should be classified as in adolescent patient. And then they somehow circumvented the issue and said that we cannot. Another letter was published, and which they said that our focus was not on generalized aggressive periodontitis. We agree it is difficult to differentiate between chronic periodontitis and generalized aggressive periodontitis. LAP, that is localized aggressive periodontitis. Another important thing which they pointed out here was it was a consensus. That consensus means the majority of people, what will they say about this, and it is very clearly said that in this workshop it was very minor consensus positive note which people were agreeing to remove it. So it was not a majority consensus, and the consensus should be mentioned that 60%, 50% people agreed to remove this. That was not mentioned because it was by a very minute majority that LAP was removed from classification. And then Dr. Zamba again and that why this when necrotizing has contained that just the academic of this. After this, what is articles which are published in JCP? Early on in 1999, and very interestingly, I will show you JOP. Now, how many names are in this classification for patients which are basically LAP patients, but they now want to differentiate it between an adult patient and a juvenile patient. So different names have started, early onset, all these names, which will confuse everyone, in the long run. Now, another negative aspect, you have defined periodontitis that 2 mm of attachment loss interdentally in non-adjacent teeth and a buccal and a something very important. This loss of attachment should not be ascribed to any of have certain periodontitis it becomes much more difficult. It is not just 2 mm. You have to diagnose them as a case of periodontitis. So, one type of periodontal destruction is you have to do a site periodontal destruction. If only 1 8 mm, rest everything is normal. You cannot call it because you have to have 2 sites of periodontal disease. You normally, when you diagnose it, you do not the child is they just who is going to sit and measure the child? Then the measurement with CAL with the standard probe has errors, especially in the initial cases. Is possible and means of 1 mm, 2 mm attachment loss interdentally, where you cannot find CEJ, you can misdiagnose those cases very easily. Now, staging, you have complexity factors, which is the new addition, as I said, ridge loss and how these were lost, all patients, and they can be misleading and not any time. So this factor becomes very difficult to use in a case of classification. Now, see, grading, they say on the basis of radiograph. The radiographs give you, first of all, many of us are working in dental colleges. Think how many patients in your clinic, in your departments have got 5 years of radiographs to see and diagnose a patient. Who will have 5 years of radiographs to diagnose the grading of the patient? Which patient will keep radiographs for 5 years to give it a grading? Second thing, they said, use bone bone 50 if you have a 4 loss in a 10, so 40% loss, that is it becomes a grade D. Okay. Now, what is very interesting here is that they have for a 50-year patient, they've taken by default the age of 50. But imagine, does for the 50 years of age, he has permanent teeth erupt at the age of 13. So if I reduce 12 also from that, the stage changes. It becomes a grade C stage because his permanent teeth only started erupting at the age of 12. So this grading system is not right. Secondly, the more important problem that I see is, how do I know what stage did the disease start? So by default, they've taken that the time the person was born, the disease started, and it has been divided by age. Suppose I have periodontitis now, and my disease started only 4 years back. So I will become a stage 3, say it's C. But because my age is 48, I will be diagnosed as stage or grade B. Sorry, grade B. So grading on the basis of RBL again is very misleading. Then they say case phenotype, heavy biofilm presence, grade A, grade 2. If patient gets a scaling done in one clinic, comes to you after scaling, this becomes redundant. Then see, the third disadvantage, you have 2 categories of systemic diseases. The 1 and 2 is in periodontitis. The third is where it is independent of periodontal, the destruction which is taking place, independent of periodontal inflammation is stage 3. And you know the 3 classifications which I have shown you, the sub-classifications. Okay. Now see, what they say is, should diabetes associated periodontitis be in the distinct diagnosis? They say diabetes is an important modifier and should be included as a clinical diagnosis of periodontitis. No characteristic phenotypic feature that is unique to periodontitis with diabetes. Same thing is said about smoking, that there is no unique feature which makes it to diagnose it as separately. But then they diagnose it also under systemic diseases. So whether you should diagnose a case of periodontitis under periodontitis because of systemic, not very. Then from these, the definition to classify is only applicable on buccal surfaces. That too has been applied after phase 1 therapy. Now, in one of webinars where I was attending and Mario Sanz was there of Osteology Foundation, I asked him this question, that why is that you have not included classification on lingual side? Now they said that recession has to be treated because it has got, maybe hypersensitivity, it has got thin biotype. I asked him, does the thin biotype not exist on lingual side? Can hypersensitivity not occur on lingual side? Should we not treat those? Why it is not to be classified? He had no answer to it. He said that can be treated by desensitizing toothpaste. So that is not the answer. So this classification talks of only buccal decisions and not on lingual decisions, but lingual decisions exist and they need to be noted. And you have all these things which have to be noted. It is not just recession. You have to note down recession depth. You have to note down, thickness. You have to note down whether there is any non-carious lesions which are present at the CJ or not. All those things have to be noted in this classification now. So the side effects, why recession is treated, as I said, hypersensitivity, caries, do they occur only on buccal sites, that we have to record only buccal recessions, not the lingual recessions? Last, you had a category which said that tooth and prosthetics related factors. Now they said that this is what they classified, which can cause periodontal disease. These are factors which cause periodontal disease. Ultimately, they said that tooth anatomical factors and in relationship in arch are related to dental plaque biofilm. Ultimately, they cause dental biofilm gingivitis only, but it is a separate category that suppose someone has an enamel pearl, you need to diagnose this as a anatomical aberration which is present there. Maybe he does not have gingivitis. So you need to look for all those things and diagnose them. So the end of the present, the talk of the town has been everywhere. The aging and grading and not things. There are few good things, case definitions are good. Periplant disease is good. There's a long list of things which are impractical and difficult to follow. And the ugly part of this class is that 2018, 2020, still you don't find it in books. I don't know as a UG what should be for UG. Because they don't have access to journals. They 5 years classifications. Out of 50 have been given only after 1970. So how long will it last? The time will only tell. I don't know how long will this classification last. Maybe in another 10 years you will have a new one. But I would be the happiest person to have Indian Society of Technology classification system which could be used across the world. Could have someday. Thank you so much for your patient hearing.
Thank you, Ashish, for a wonderful presentation and clarified the understanding of the 2017 classification. But I hope till the time we understand it fully, a new classification system would be in place.
Maybe I'll be there to explain the new one also, sir.
Yeah, sure. And that's what myself and Dr. Nimfe were talking. The classifications which we had read at our times were more simpler and easier to be understood. And year by year, the complications, the understanding of the classification is getting complicated. And your dream of ISP classification is also the dream of our president, Dr. Anirban. And he's working on it and hopefully we'll get it by this year. Thank you so much. And I suppose we're running a bit late because of the AC plant delay. And if anybody has a question, they can catch up Ashish anytime during the day or tomorrow, the whole day he's here. And we will start with the next session. Baljit sir.
Thank you, sir, for saving me from questions.
It is backstage, Ashish. I have not saved you.
Thank you so much, sir, for making this session informative. Now, I would like to request the chairpersons to kindly felicitate the speaker. huge round of applause, audience. Now, I would like to request Dr. Shiva Manjunath sir to felicitate the chairperson.
Aesthetic periodontal surgery has seen a huge shift over the past few days, as it's clearly evident from the change in nomenclature from mucogingival surgery, periodontal plastic and aesthetic surgery, and we certainly have come a long way. The current session gives us more knowledge about the topic alternatives to connective tissue grafts. Do they even exist? Now, to begin with this session, I would like to call upon stage our first chairperson of this session, Dr. Anirban Chatterjee, sir. He is the current president of ISP. He is the president of the Goma Periodontology branch of Bangalore. He has 75 publications in international and national journals, 627 citation, and he is on the editorial board of 6 journals. We welcome you, sir.
The next chairperson I would like to call upon stage is Dr. Abhay Purni, sir. He is the professor and head of Department of Periodontics, BSPM Dental College and Research Center, Nagpur. He is currently the president-elect of ISP. He is also the member of Board of Studies, MUHS, Nasik, and keynote speaker at various national conferences. Sir has to credit over 100 publications in national and international journals. He is presently a life member of ISP and ISOI. We welcome you, sir. Now, I would like to call on stage. I would like to request the chairpersons to introduce the speaker of the session. Dr. Nitin Dani.
Thank you. Good afternoon, friends. The next session would be delivered by Dr. Nitin Dani, and it's my pleasure to introduce him. He has a teaching experience of over 24 years in dental college at Nasik, and he did his master's in 1985 from the prestigious Government Dental College and Hospital, Mumbai. He has a successful private practice for the last 36 years, specializing in oral rehabilitation. He was a former president of ISP in the year 2017-18. He has over 50 publications in various aspects of periodontology in the national and international journals, and has published 5 books on various aspects of periodontology. So, present graphs, do they even exist? So, over to you, Dr. Dani, sir.
Thank you so much. Good afternoon, friends. I'm back in Chandigarh. I've been here in and out so many times in the number of lectures that I've given that it's a second home to me. Ashish Jain, Baljit Singh, GP, they're now like close family members to me. And thank you so much for the introduction, Chairperson, sir. Basically, what they were trying to say is that an old guy who's done his BDS 40 years ago, practiced for 35 years, taught for 25 years, is trying to tell us something that we already know, whether there is an alternative to the connective tissue graft. Do they actually exist? This is what I'm trying to say. Before I go ahead, let me tell you, all the cases that I'm going to show you are done by my postgraduate students when I was a teacher for their MDS dissertations. Some photos used for illustrative purposes have been taken from the internet or from the textbook or from atlases to help you understand certain things. And none of these images have been digitally altered or modified in any way. What we have shot, we have showing you. Photography has come a long way. So most of these things that were shot maybe 10 years ago might not be as wonderful as the photographies that we see now. Now we all know free gingival graft was the most widely used graft since its introduction by Bjorn in 1971 and was primarily performed for increasing the vestibular depth, or what we used to say is widening the zone of attached gingiva. There have been a lot of publications on the success of this free gingival graft for root coverage, but in clinical practice, the root surface, like she told us just now, that it is difficult and sometimes you get unaesthetic results due to the peculiar anatomy of the donor. That you're taking a graft from the palate do not match the labial gingiva. Now, free gingiva replaced by CTG for most of perioplastic procedures, and especially the root coverage procedures, which are in vogue now for the increased demand of aesthetics from the patients, and it's matched by the supply from the doctor. So this is a case where you can clearly see gingival recession is there, and very nicely one of my PG students took a graft and he put it there. He said, "Sir, ये तो अभी cover हो जाएगा recession." So I said, "Okay, let's hope that some root coverage takes place." He said, "Sir, मैंने वो suturing वगैरह भी बहुत अच्छी तरह से पढ़ लिया है, वो Holbrook Austin suture डालूंगा." I said, "Okay, fine." The wonderful suturing was done, and see what happened. Only widening of the attached gingiva was attained. We could not get any root coverage in this. Now you will say that this is not an ideal case to try root coverage. What I'm trying to say is this is difficult on a space. What happened as we grew, we started doing the procedure. First stage, you put the connective tissue graft, free gingival graft, widen the zone of keratinized gingiva. Then you perform a coronal advance flap. You do this up coronally. Let the tissues get covered completely. This particular graft, it is not a free graft anymore. So it is more successful over here. It will be viable. And then this is the result that you can obtain. Now this is a microsurgical procedure that is done. This is not a case done by my PG student, like I told you, for illustrative purposes. So then used it to treat alveolar surgical procedure. Coronally advanced flap, like a tunnel and pouch and all the list. You plastic good amount of success was there in this type of technique. Then Langer said we'll place it subepithelially. So this is a typical case of a recession. Flap is raised, connective tissue graft is sutured subepithelial. This is under the epithelium over here. And you can coronally advance the flap and you can expect good amount of root coverage in this. Now CTG can be used with a tunnel and pouch also. So you can just take a CTG and thread it right through here, all across in this tunnel, and then suture it properly and then expect good results. And the latest technique which our President Sir has worked a lot about is the Vista technique, where there is a so that's where you take your incision in the vestibule and then you tunnel under this over here. Now I would like you to look at the suturing that is done. These composite buttons have been put over here because later down the presentation you'll have, I am showing you certain cases where we have modified this sort of a suturing technique and then everything is put in place and you get wonderful results. Sir has used PRF along with the Vista technique. So I'm going to talk about the use of PRF also. So that brief introduction of what has been happening brings us to the fact that why alternative to CTG? Why am I standing here? Why am I speaking to you? Because sometimes we need to eliminate the need of second surgery. When you tell a patient, I'm going to do a coronally advanced flap, patient is ready because he has to cover his recession. Then if you tell him to improve the success that I'm going to do another surgery, I'm going to go to a healthy area, I'm going to take a tissue from there and I'm going to transplant it over here, then things start getting complicated. Then they start wondering whether they should get it done or not. So to eliminate the need for second surgery, especially its expertise and morbidity. Now, we are all periodontists or going to be periodontists. We are going to be experts in doing that. But that thing should be there that there is a definite morbidity for any second surgery that is going to take. Conventionally, alloderms or enamel matrix derivatives have been used. But what I'm going to talk to you about is some unconventional alternatives like glass ionomer cement. Now you will say, what has glass ionomer got to do? PRF, chorion membrane. These are some unconventional alternatives which my postgraduate students studied when they were doing their dissertations. So they're basically a comparison between this particular alternative and the CTG during a coronally advanced. And like the use of orthocleats or bridge flap or a modified bridge flap, that is. So let's start with resin modified glass ionomer cement. This was a dissertation by Dr. Rakesh Mutha done 12 years ago. A clinical evaluation of coronally positioned flap on a restored tooth surface against a connective tissue graft in a non-carious cervical defect. So there is no periodontitis involved here. Patient got a cervical defect which is not carious, maybe due to recession, abrasion, use of toothpaste aggressively. So on one side, now when you do a comparative study split mouth, you have to have two sides which are identical in the same patient. So you can see here, this is the non-cervical, non-carious cervical lesion. And this is a standard incision for a coronally advanced flap where take an incision across the papilla, take vertical releasing incisions. Then the flap reflection, partial, full, partial. This is left covered with connective tissue, periosteum removed from here, and as you go apically, you have to again go in for a partial thickness flap. Then the connective tissue graft obtained from the palate, placed over here in place and coronally sutured. And this is what got when the suture removed. Now on the other side, what we did, we restored that particular defect, exactly same type of defect on the other side. We restored it with glass ionomer cement and then same coronally positioned flap and this is the result that we got. Now, if you look at the results next to each other, compare, let's see what we can get here. So this is the initial defect. They both look quite alike. And this is a few weeks down healing. And this is what we got at the end. In the beginning, when I said photography has come a long way, this was the type of photography we used to do at that time. We didn't have any courses on dental photography also. So this is the results. They seem quite okay, but I'll tell you an interesting fact. What we got was an overfill with CTG. On this side, on your left is the CTG, on the right is the resin modified glass ionomer cement. So now if you place a line across the adjacent teeth, you will see that this particular area, there was an overfill. Now if you are doing this case for an aesthetic purpose, in aesthetics, all your gingival zeniths have to follow a particular pattern. So you cannot do this here because the patient then, let's say this tooth is looking shorter than the other. That's because the connective tissue graft will not differentiate between the defect on the enamel and a defect on the root surface. It will just take up that area, and once it gets covered with a flap, it will integrate. Now you cannot do crown lengthening in this patient also because inside there is a defect. So if you go to see aesthetically, I would say that my resin modified glass ionomer cement has worked very well for me. If this patient has come for sensitivity purposes, also it has worked very well because we have restored that particular surface. So what results did we get? Glass ionomer cement resulted in a mean root coverage of 62% as compared to 75% with CTG. So there's a difference of just 10-12%. And a maximum of 79 root coverage was seen in 4 out of 15 cases as compared to 100% in CTG in 8 out of 15%. So these statistical terms are sometimes very confusing. What is mean root coverage is total number of cases that you have seen, how much roots were covered. And maximum root coverage is that in a particular case, how much root was possibly covered. So CTG was good, but resin modified glass ionomer cement wasn't too bad either. Next we did platelet rich fibrin, a clinical evaluation of an autologous platelet rich fibrin, laterally positioned flap for the treatment of isolated denuded root surfaces. Now here we are not compared with connective tissue, but there are certain inherent drawbacks of a laterally positioned flap, which we could overcome by using a PRF. Typical case where we see an isolated recession, we cannot take a lateral graft from here, so it is taken from the other side. This is your typical lack of attached gingiva, keratinized gingiva in a recession. And then lateral sliding flap was done. Flap is taken from the adjacent side and shifted. But what we did before we sutured is we prepared a PRF membrane. Now this was done 10, 11 years ago when PRF was just coming in. And we sutured that and then slit the flap, put it in place. This PRF is left open over here. This is the donor side. This is the recipient side. And this is what we got. If you look at a closer view, this was the recession pre-operatively and post-operatively. Everything is in one line. Wonderful results we got. Now, drawback of a laterally positioned flap is that there is a lack of sufficient root coverage. So, literature overall says that around 67% of the cases you can get root coverage. And there is recession at the donor side. So you steal from Peter to pay Paul, and then you lose at both places. So in our case, we got a mean root coverage of 74%. So adding PRF to the laterally positioned flap increased the success that we got. And we got a recession reduction of 3 millimeters. And there was no recession seen on any of the donor sides in the 15 cases that we did over here. Now, this is another membrane that is available with Tata. the chorion membrane, you have an amnion membrane also, you have an amnion and chorion membrane also. So we studied gingival augmentation coronal to recession, that is trying to cover the root using a coronally advanced flap with a connective tissue graft on one side and a chorion membrane on other side, done by Dr. Vaibhavi Bhatt in 2014. So standard coronally advanced flap, again the same technique, cut through the papilla over here, partial, full, partial reflection of the flap. Now this is the membrane. Now this is readily available. You just soak it in the blood of the patient and put it there like you are putting a connective tissue graft over here. So no second surgery is needed in this particular case. And then suturing, and this is the result that we got. Preoperatively, you can see the recession over here, the root exposure, and this is now, of course, it will heal a little further and, sorry. This will also resolve over here. So this was giving us good results, but not as good as the connective tissue graft. So connective tissue graft showed more mean root coverage, that is 85% mean root coverage, and total root coverage was 66%. So in 66% of the cases, we could cover the entire root that was denuded, while chorion membrane gave us 76% mean root coverage and 46% total coverage. So it is not that we did not get anything. We could not match the gold standard connective tissue, but we did get a sufficient amount of root coverage, and that too in quite a number of patients. Now this is interesting. The chorion membrane scored better on patient-centric outcomes. Now, as we have moved from 2010 to 2014, more focus on what the patient wants, what are the tangible benefits and outcomes has come. So, chorion membrane scored better on patient-centric outcomes like post-operative pain, swelling, and discomfort. What is the patient interested on? Root coverage he wants, but he doesn't want pain, he doesn't want swelling, he doesn't want discomfort. Now, what was the reason for that? It may be due to lesser surgical time. So we evaluated how much time to do a connective tissue graft with a coronally advanced flap. It took us 1.5 hours, 93 minutes, as compared to 45 minutes to do a chorion membrane. The patient is in and out in 45 minutes and has got sufficient amount of root coverage, is definitely a plus point for all of us. Now, in the Vista technique, I had shown you the suturing that was done by the composite buttons. Now we have used orthodontic cleat attachment. So a comparative study of gingival augmentation coronal to recession. Now this is a different technique that only to stabilize the coronally advanced flap with the suture, we have used an orthodontic cleat done by Dr. Marekna Raghavan. So this is the recession. So what we did is to enable us to get this flap well covered over here. We put these orthodontic cleats, they're readily available. You just bond them onto the tooth. And then Zucchelli's modification was done over here. You can see these incisions over here like this. And then this flap was raised. Again, same partial, full, partial. And then completely covered the recession and sutured it right to the orthodontic cleat over here. Now, we did not compare this with a connective tissue graft because a connective tissue graft is used to improve the success of the coronally placed flap. The basic surgical technique to cover the root is a coronally placed flap. So now this is what we got. Pre-operatively, you can see there is a significant amount of recession, and post-operatively, we were able to cover quite a lot of recession by using an orthodontic kit to fix the flap well in place till the healing took place. Now, suturing with the orthodontic cleat resulted in a mean root coverage of 82%. See, the success rate is going ahead and ahead as the years go by. 8 out of 15 sites showed us 100% root coverage. That means the entire root that was open was covered. And these results were better than suturing without the cleat. So when we do just a coronally advanced flap and use something to stabilize the suture, that technique has definitely resulted in a better surgical result. Now this is the last type of case I'm going to show you, the bridge flap. It was done by Dr. Priya Thakkar. The efficacy of a modified bridge flap procedure to increase the width of keratinized gingiva and cover the denuded root surface. So two objectives are there. Augmentation of gingiva coronal to recession as well as apical to recession in one single procedure. So you're going to do two things in one single procedure in a multiple recession case in a mandibular anterior region. So maximum amount of recession we see in mandibular anterior. Generally, it is not amenable to any of these root coverage procedures because they work well in isolated denuded roots. When you have 2 or 3 or 4 roots next to each other which are denuded, the success rate is not too good. So we try to do a bridge flap. So preoperatively, you can see local factors or what in the classification, whatever it is called, I don't know. Recession, lack of keratinized gingiva. So this is after the scaling was done. Now you can see only about 2 millimeters of keratinized gingiva. In our terms, it used to be attached gingiva. We never considered the sulcus as a part of the gingiva. It was the keratinized gingiva. And then this is the recession. 3 millimeters of recession, 2 millimeters of keratinized gingiva. Now, the two procedures that were done were as a fenestration procedure and a bridge flap. What is a fenestration procedure? You take an incision in the mucogingival junction, you expose the periosteum and you can strip it off if you want. So this is an incision that is given and this is the fenestration. So incision is given at the mucogingival junction and a part of the periosteum is stripped off. The aim is that this area will heal by secondary intention. So the new mucogingival junction would be formed much apical to its existing location and a scar formation would take place which will prevent the creep of the mucogingival junction in the coronal direction. Now this is the flap that has been reflected. Now why is it called a bridge flap? Because it is attached on the two sides and it is removed from the middle. So it's like a graft, but it is not free. It is attached at two sides. So you have sources of blood supply coming into that graft from the two sides as well as from the base. And now it is being shifted coronally. And it is still attached to these two sides and it has been shifted coronally. Now in this position we have sutured it. Standard suture. We have this periodontal dressing. And when the dressing was removed, this is how it looked. And when the sutures were removed, this is how it looked. Then we waited. As you know, we have to wait for the complete healing. So after 1 month, this is what we got. And after 3 months. Now you can see isolated, they were not isolated, there were multiple adjacent root recession cases that were solved by one single surgical procedure. So we got gingival augmentation, coronal as well as apical to the recession. This is what we saw pre-operatively. This is where the recession was. And this is what we saw post-operatively. This is where the recession was. This is the augmentation that we got coronal to the recession. And this is the augmentation that we got apical to the recession. A very interesting procedure. Could be said to be a little more traumatic than others because the fenestration procedure is there. Now, what were the results? 3 millimeters increase in width of keratinized gingiva. So, from 2 millimeters, we went to 5 millimeters. 3 millimeters reduction in recession with a gain in clinical attachment level. So, the root got covered. 100% root coverage in 18 out of 30 cases. So, we did 30 of these cases where we got 100% coverage in 18 cases. And at the end of 6 months, the mean root coverage was around 85%. So it gives you wonderful results to see such a case being done. So now, although CTG is gold standard. There is no doubt about it. CTG is gold standard, but none of our dissertations found results that were statistically significant when both the techniques were compared. So CTG versus glass ionomer, CTG versus chorion membrane, none of the results were significant enough for us to say that there is no alternative to gold standard CTG. So we must be ready with our alternatives to achieve optimum results for our patients. Not all patients will opt for second surgery. You tell a patient do second surgery, he will not opt. And not all surgeons may want to do a second surgery. Though we are all trained periodontists, our bread and butter, bread is the scaling and butter is the flap surgery. If you tell somebody do connective tissue graft, maybe that person doesn't have the confidence to do the connective tissue graft. We should all be able to do a connective tissue graft, not with our eyes closed or our hands tied behind our back, but very confidently. But not all surgeons may want to do a second surgery. It's unfortunate, but it's a sad but true story that people now don't want to do, or they don't feel confident enough to do this sort of a surgery. When I gave these particular dissertations to my students to study, one of my aims was that they should be proficient with this particular technique. Coronally advanced flap, connective tissue graft, they should be able to do it. One of my students, whose case I showed you, who used the chorion membrane, even in her exam went and told the examiner, Dr. Biju Thomas sir, that I want to do a connective tissue graft as my exam surgery. But then you know how we old timers are. We said, no, what if you can't do it properly? What if you fail and we will have to cut your marks? So she said, sir, I am confident I will do it. We have to move out of our comfort zone in the examination and ask our students to do all such things until and unless they do it. They will not go ahead and do all these things. So yes, alternatives to connective tissue grafts do exist. If one is willing to forego some amount of root coverage, instead of 100%, 85%, and that too in few patients. So not all roots might get covered and not all patients will get 100% success. But definitely alternatives to connective tissue grafts do exist, and they have to be used routinely in patients who don't want a second surgery. I'd like to express my sincere gratitude to the ISP study group of Chandigarh for this wonderful event and giving me the opportunity to speak here. To my postgraduate students who allowed me to present their cases, and especially to all of you who are sitting here giving me a patient listening. Thank you so much.
Thank you, sir. Our dynamic, spirited Dr. Nitin Dani, sir. Wonderful case presentation. It is definitely, it's alternative. We have so many alternatives, especially the bridge flap, which I've done many cases as it's shown. And just a point I just want to add in this, the Vista technique, what I did, the suturing you had done with the ortho brackets, but I have taken from palatal. I took the palatal, yeah. Because first time when I did, it came off with the button, the composite. So again, that same patient, we did it and sutured it in a different way. And as you mentioned, instead of what Zade had used, I had used.
So as clinicians, we get such wonderful opportunities to do good research and do it.
Exactly.
I think your symposium is on that only, that
Yes,
how to improve the research. So until you think how you can improve what is going on, you will never try new things. Time and tested. Like I said in the exam, we still do Kirkland flap. It's been 100 years since that flap.
Exactly, sir.
So I think we have to move ahead and we have to try a different thing.
We as sir has mentioned, the CTG is a gold standard, but the results, if you see, to be very frank, you don't get that result what they have got from other than CTG. Though it's a gold standard, like again, like how we tell chlorhexidine is a gold standard. Like that, there are now other mouthwashes also, which is giving a good standard comparatively. So, sir, it was a really, really informative. Then hopefully our PGs, whoever, we have to step beyond this. We have to go beyond this.
Speak after Ashish speaks, because the amount of matter that he has in his one slide, I don't have in my entire presentation.
No, no, but you have shown the clinical cases.
Yeah, so there
Yes,
are two ends of perio, academics and
yes,
I mean
yes,
research
both the things
and
was taken.
etiopathogenesis and clinically how to apply. So you are oscillating. I hope this oscillation continues for your benefit.
So, our smart, handsome Dr. Dani, spirited person, has shown all the spirited thing work which has come and wonderful cases. So I would urge all the PGs, just take it up. Don't shrug behind not doing the cases. Now, whatever said and done, you are now, by choice or chance, you are a periodontist. You have to. So learn that. So thank you, sir, for a wonderful presentation.
Thank you so much, sir, for making this session more informative. I would like to request to the chairpersons to kindly felicitate the speaker. Thank you, sir. Now I would like to call upon stage Dr. Mangesh Padnayak, sir, to felicitate the chairpersons. We will resume the session at 2:30 p.m. after the lunch break.
या बिल्कुल। आप कहाँ से? गुड मॉर्निंग, गुड आफ्टरनून, गुड इवनिंग एंड गुड बंद कर दो।
I hope you all had a sumptuous lunch. Move to the scientific session. The diseases of periodontitis are as old as recorded history of mankind and can be verified by signs of periodontal disease of the earliest humans. Our understanding of periodontal disease therapy has changed greatly over a period of time as a dentist.
क्या हाल है सर?
The contribution of periodontology in the treatment is as necessary as any other specialty. We would like to begin our next session on the topic. Let us explore the dental world from the eye of the periodontist. Now, to begin with this session, I would like to call upon stage our very first chairperson, Dr. Anil Melat sir. He's currently working as principal professor and HOD in Department of Periodontics and Implantology, Mahe Institute of Dental Sciences and Hospital, Mahe. He has been awarded Most Proactive Senior Academician in Periodontics in 2019. Sir has been the past president of Indian Society of Periodontology in 2018 to 2019, Vice President, State Dental Council, Puducherry, the President of Indian Society of Prosthodontics, Restorative and Periodontics. We welcome you, sir.
Now, I would like to call on stage the next
I'm fine, sir. Better.
chairperson, Dr. H.S. Garover, sir, Secretary of the Indian
Thank you.
Society of Periodontology since 2019. He did his post-graduation in periodontics from the prestigious King George Medical College, Lucknow in 1988. He is the presenter of more than 100 scientific papers. Sir has more than 145 publications and contributions in 7 books on various topics of periodontology. We welcome you, sir. Now, I would like to request the chairpersons to kindly introduce the speaker of the session, Dr. Vikas Jindal, sir.
Good afternoon. It is my proud privilege to introduce Dr. Professor Vikas Jindal for the lecture you are going to hear just now. Sir is currently the Director Professor and Head, Himachal Dental College, Sundarnagar. He did his bachelor's and master's from GDC Amritsar and is practicing and teaching periodontology for the last 26 years. Managing dental colleges in Himachal Pradesh, Himachal Dental College, and running a pharmacy college at Nalagarh. Sir is a pioneer in introducing implant dentistry in Himachal Pradesh. General Secretary of Samvedana, an NGO serving free the accident victims and poor persons through a fleet of ambulances and also providing mobile mortuaries to them. So here I call upon the legend himself, Vikas Jindal sir, to kindly deliver the lecture. His topic is, very interesting topic, let us explore the dental world from the eye of a periodontist. We welcome you, sir.
Thank you very much, sir. वक्रतुंड महाकाय सूर्यकोटि संप्रभा निर्विघ्न कुरु मे देव सर्व कार्येषु सर्वदा. At the very outset, I would like to thank the chairpersons for such a wonderful introduction. Thank you very much, my elder brothers, younger brothers sitting in the hall, my budding periodontists. I would like to thank the organizing committee for giving me an opportunity to talk on this topic, and also for organizing this conference after a gap of almost 2.5 years. So we could see the day of the light and we could all sit together and would be able to talk to each other on the various topics during the course of the day. This is from where I come from, Himachal Dental College. I am teaching here for the last about 26-27 years. This is my family which is there at Himachal Dental College. And my present family, after I met with an accident in 2019, people say life आपको बहुत लड्डू देती है, and as somebody has said that life आपको नींबू भी बहुत देती है, lemons, and you try to make lemonade out of lemons, but it is not easy to make lemonade out of lemons when you reach this stage of sitting on the wheelchair. But I'm thankful to my family, ISP, and my family, particularly my personal family, who have always stood with me through all these 2.5 years. And I have been able to sit before you and talk to you on this topic. Whenever I talk to my postgraduates, I always tell them that post-graduation is not just a degree. It is a way of life. Similarly, when you see this world of dentistry, you have to see this world of dentistry from the eye of a periodontist. You can be a successful dentist only if you see this world of dentistry from the eye of a periodontist. May I know in this hall who all want to be millionaire? Can you raise your hands? Who all want to be millionaires? I'm very happy. Somebody is raising 2 hands together. And who all want to own these? Or who all want to be on the behind the wheels of this car? I assure you, my dear friends, that by the end of this presentation, you will know the secret of these slides, because if you have the aim and you work in the proper direction, you are sure to be the winner, sure to be the winner. I am in the habit of distributing chocolates. So my friends call me the chocolate man. So I have brought a whole bunch of chocolates with me, and I'll be putting forward some chocolate questions to you during the course of this deliberation. So my first chocolate question to the chairpersons, to the mentors, to my colleagues, and to the students here is, who is a periodontist? May I know who is a periodontist? Sir, please. The chocolates, my postgraduates, please be on the toes, because you are going to distribute a lot of chocolates here. Sir, anybody who can tell me who is a periodontist? 2 chocolates for Dr. Balji. Yeah, 2 chocolates, sir. Anybody else? Any student sitting here? Many budding illustrious prosthodontist, a periodontist who is sitting here. Yes, please.
The one who takes care of the entire oral cavity, because it is the periodontium only that is supporting each and every tooth in the place.
Perfectly fine. Please sit down. Chocolate for the young lady there. Perfectly fine. No, I am not looking for the bookish definition, because you have to see the dental world from the eye of a periodontist. So periodontist is the one, you are right, who takes care of the dentition as a whole. To my mind, periodontist is the one who creates smiles. Periodontist is the one who sculpts smiles. Periodontist is the one who respects smiles and who knows how to create smiles and how to maintain them. I was surfing the internet and I just came across a video. I would like all of you to watch this video for me. Please.
Recently, one of my friends came up to me and he criticized me, right? But he criticized me for something that I have never been criticized for in my entire life. He said, and I quote, "यार वैसे तो बंदा बड़ा प्यारा है, पर यार तेरे मसूड़े बड़े गंदे हैं." Exactly. It took a little time for me to register this completely. मैं कहा हाँ यार, I have to work on it. एक मसूड़े? मसूड़े होते किसके अच्छे? मसूड़े कोई एलिगेंट बॉडी पार्ट नहीं है. Like you'll never see guys talking about girls. भाई बंदी क्या मसूड़े थे यार. बंदी का ये वाला पार्ट सुंदर है ना, ये वाला मजा आता है.
So this is what the general perception is, that Musude are not the elegant part of the body. See, if Musude had not been elegant part of the body, would we have liked such smiles? Never. Musude are the elegant part of the body, therefore we like this smile. Musude are the elegant part of the body, therefore she has been ruling the Bollywood for quite some time. Now this favorite actor of mine has a gummy smile, but they are the elegant part of the body and he is one of the superstars of Bollywood. Therefore, my dear friends, you have to have a good smile because smile does make a difference. And smile does make you different from people in this entire world. So, next slide, please. I would like to tell my budding periodontists that you are in one of the best branches of dentistry, because after you become a class periodontist, you are going to be one of the best dentists in this world. And I will tell you certain facts about that, and you will understand why. You know, if you intend to give the best possible treatment to your patients, you need to, harmoniously integrate all the specialties so that in all inclusive treatment can be planned for the patient to visit your clinics and your hospitals. But for that, we need to understand the biological basis of the periodontal ligament or the periodontal tissues. We must know that the periodontal tissues are the backbone of dentistry, as one of this lady nicely said, and periodontal tissues are responsible for aesthetics, for functions, and for comfort of any individual. Now, when we talk of, go slow, when we talk of the gingival tissues, we talk of the gingival texture, we talk of the gingival shape, its tooth-to-tooth progression, its relationship to extraoral tissues. It depends upon a number of factors, but the most important factor is the anatomy of the dentogingival complex. We need to know, when we talk of dentogingival complex, what is the level of gingival sulcus. We need to know what is the level of junctional epithelium. We need to know what is the level of connective tissue attachment. Now, in human body, we all know we have ectoderm, and ectoderm saves us from the outside environment or the bacteria. But the tooth must penetrate the ectomesenchyme. And once it penetrates, it comes to the outside environment. But the underlying tissues are protected by a band of tissues, which is continuously, around the tooth. And that dimension of this tissue, which surrounds the tooth when it erupts in the oral cavity, is known as biological width. And in the latest classification, it is known as the supracrestal tissue attachment. Now, when we talk of the biological width, we must understand its significance. What is the significance of biological tissue? The biological tissue forms the lifeline of the tooth. Therefore, I always say it is like the Great Wall of China, because it protects the underlying connective tissue. It protects the underlying alveolar bone from the outside invasion of the bacteria. Therefore, it is the lifeline of the dentition. Now, the chocolate question to everybody is, can anyone tell me what is the dimension of the biological width? Please, 2 point. Please distribute chocolates amongst all. To his students, beta, not does. से आवाज आई है, सारे ब्लॉक को चॉकलेट बांट दो. Yes, you are right. It is 2.04 millimeters, sorry. Okay. Now, this shield is most effective when it is not broken, when it is intact, because violation of biological width can lead to the destruction of the underlying tissues. It can lead to precarious outcome. Here, this photograph, this person is partly safe because he is away from this first stop, because that shield is inside. But once the shield is broken, see what can the outcome be. So we need to save that shield. We need to be sensitive about that shield. For that, we need to understand the principles of biological width and its relationship to the underlying periodontal health. That is most important to understand the importance and the principles of biological width. Now, when we talk of this particular supracrestal connective tissue fibers, we have to understand that when we do general dentistry, we do restorative procedures, we do crown procedures, and for that particular thing, the restorative margins have to be placed in an area that this width is not disturbed. We have to maintain this particular width because any insult to this biological width can lead to irreparable damage to the underlying tissues. We all agree to this. So there has to be a minimum of 3 millimeters of space between the most apical part of the restoration and the alveolar crest. That is the baseline we must understand. So there have to be sufficient room which should be allowed for the supracrestal fibers and the connective tissue. Because if we maintain that respectable distance, only then we can have the desired results. So my dear friends, if we fail to do that, if the biological width is disturbed, then it reestablishes itself. It reestablishes itself because after that you lose the tissue and after that it reestablishes. Kindly know that we need to have that particular comfort zone between the restorative margin and the biological width or the alveolar crest. Now, if you see this photograph, this is the American president. When he visited China, he kissed the Chinese premier's wife. But when the Chinese premier visited America, he kept her at a safe distance. He kept her at a respectable distance so that some destruction could not be caused in America. So I would like you to watch this video for me.
The distance from the base of the pocket to the crest of the bone is the minimum distance required between the bone and a foreign material, like a filling or a crown. If the filling or crown margin came too close to the crest of the bone, then the body's natural defenses would try to reject the crown, causing redness, inflammation, and possible pain along the gum line. A minor procedure can change the shape of the gum and bone in that one area to create enough distance between the crown margin and the bone, allowing for healthy placement of the restorative material.
So my dear friends, for a restoration to be long-term in the oral cavity, we have to have a healthy periodontal tissue in the oral cavity. And for the placement of the crown, it is important that the tissue is healthy. So they have an intimate relationship, which we must know and we must respect. When we talk of periodontal restorative interrelationships, what are we really aiming at? We are aiming at the margin of the restoration. We are aiming at the margin of the restoration. We are aiming at the contour of the restoration. We are aiming at this surface finish of the restoration. Because all problems start at the margin. All problems start with dental plaque. If the margin placement is not taken care of, the periodontal health can never be healthy. Can never be healthy. So we need to undergo certain guidelines for margin placement, which we will talk just now. This is Ms. Fox. Now, when we talk of crown margins, we know there are 3 types of crown margins: supragingival crown margins, equigingival crown margins, and subgingival crown margins. For supragingival crown margins and equigingival crown margins, we don't have any problem because they are in the self-cleansing area. But we have problem with subgingival crown margin because sometimes for retention, for resistance, for aesthetics, we have to take the margin preparation below the gingiva subgingivally, and that is where the greatest risk takes place or arises. That I say a periodontal best to keep in mind the subgingival area for the longevity of the restoration. 2 different types of problems can arise. One is gingival inflammation, another is bone loss and gingival recession if we don't take off the gingival subgingival margins properly. There are certain example show you because biological width and the margins had not been taken care of. The second one shows the bleeding on probing, and the third one shows the gingival recession and the bone loss. So when we talk of margin placement guidelines, we have to take into consideration the sulcus depth. The sulcus depth varies considerably from patient to patient. In some patients, it is shallow. In some patients, it is very deep. And when we talk of the principles of margin placement, we must know that the base of the sulcus should be taken as the top of the alveolar bone when we try to make the preparation on the tooth surface, because deeper the sulcus depth, more are the chances of recession. So what things should be taken care of is this: once we take the margin to the level of the crest of the gingiva, we must understand 3 points. Rule number 1 is that if it is 1.5 millimeters, if the sulcus depth is 1.5 millimeters, we should take it 0.5 millimeters into the gingival sulcus. If it is more than 1 millimeters, we should take it halfway into the sulcus depth. But if it is more than 2 millimeters, then we should think of going in for gingivectomy first, getting the sulcus depth to 1.5 millimeters, and then carrying the margin 0.5 millimeters into the gingival sulcus. That is what will make your restoration, have a long term into the oral cavity. This was a case with us, we had a slight shorter crowns and, the increase in the size of the gingival margin. So we removed the crowns. We measured with the probe, the sulcus depth was around 2.5 mm. We went in for the gingivectomy, and the fourth picture shows, the healing part and the final crowns in place, right lower corner. So you can appreciate the difference between the first preoperative photograph. And where tooth number 3 and 4, after having removed the crown, lot of inflammation was visible. The alveolar crest, was worked on. The crown was lengthened. Temporary crowns were given, and the final placement after the work was done, so that the biological width should be respected and the crown should go a longer period of time without any inflammation or without any bone loss or without any recession. Now the next chocolate question to all of you is: how can we achieve ideal subgingival margins without abrading the gingival tissues? Chocolate men and women, please stand up. Sorry. Retraction cord. Beta, like chocolate beta betiya ko do wahan pe. Anybody else? Kya bola ji? Retraction cord. One chocolate for her also. Perfectly fine. Perfectly fine. Perfectly fine. You are absolutely right. If we want to avoid tissue abrasion, we have to go for tissue retraction. And who else can do better tissue retraction than a periodontist? Now, when we talk of tissue retraction, we should know that the reference point during the preparation of the crown is the crest of the gingiva. So initially, you carry the preparation to the crest of the gingiva. Now, for rule 1 situations, where I said the sulcus depth is around 1.5 millimeters, and you have to carry it 0.5 millimeters into the sulcus. The margin is extended on top of the retraction cord, which is placed into the gingival sulcus. In this photograph, you can see that it was placed on the top of the retraction cord. Now, if you want to record the margins after the preparation has been carried on top of the retraction cord, you place the second retraction cord, which is known as the impression cord. Because once you place the impression cord and you remove the impression cord, you can clearly visualize the sulcus depth, you can clearly visualize the preparation area, and it can be perfectly recorded. I want you to witness a little video for this so that you can have a better impression of what I am saying. Please. This is the first cord being placed in the gingival sulcus. This is how you remove the retraction cord, second retraction cord. And this is how you take the impression. Once you complete this, previous slide. Once you complete this, you will have a perfectly recorded margin. I think she pushed the button a little fast. You have perfectly defined, the margins which are recorded after you remove the impression cord. Now for rule 2 situations where the sulcus is deeper, you place the first cord, but you don't get the adequate deflection. Then you place the second cord, and then you get the adequate deflection and carry your preparation on top of the second cord, something like this. And for taking the impression, you have to put in the third cord, which is known as the impression cord. And once you remove the third cord, this is what the picture is, and you can clearly record the impressions of the margins, and you can view the gingival sulcus without really abrading the tissues, without taking into consideration that we don't disrespect the tissues as periodontists and as general dentists. That's what I mean to say is, who can do it better than us as periodontists? We know how to manage the tissues because we are more sensitive towards the tissues. Once we pass out as periodontists, we are not going to only practice periodontics, we are going to practice general dentistry also. So the respect towards the tissue is very, very important. And as a periodontist, you know how to respect the tissue. Which part of the gingiva is highly specialized and takes a lot of time for regeneration? Please raise your hand. I am not falling short of chocolates, so I can give you a lot of chocolate. Yes, ma'am. Beta, Divya.
Junctional epithelium.
Junctional epithelium. Anybody else?
Wait, sir, wait.
आधी चॉकलेट उसको एक चॉकलेट इसको प्लीज गिव द चॉकलेट जोगिंदर to my mind what my knowledge says is interdental tissue. I think the mentors will agree with me that that is the most specialized tissue and takes a lot of time for regeneration. Now when we talk of interdental tissue, this photograph shows that it is perfectly fitting into the sulcus, but there are occasions when the contact point is below, it is more than 4.5 millimeters from the crest to the contact point, and there's a too much of back to fill into the interdental space, and we come across black triangles which look unesthetic, which lead to spit firing. So we need to fill them also. And as periodontists, we can either do adhesive dentistry. Next slide, please. We can either do adhesive dentistry. In this case, we had a patient where we recall after 1 year, and it shows that the tissues and the filling is in perfect harmony with each other. Also, as a periodontist, we can go in for certain surgical procedures wherein we can use connective tissue grafts and fill that area, and you can see the preoperative and the postoperative photograph in this slide. Now, my chocolate question again is, which procedure did we follow in the last slide? Sorry. Which procedure did we follow in the last slide? Go back, please. Come back to the question. Sorry. Mentors are supposed to answer.
Sir,
only the students.
Connective tissue graft.
Sorry.
Connective tissue graft.
Connective tissue graft. Who said that? Big clap for that man with a modified semilunar incision. Perfectly fine. Yeah. So, my dear friends, the crux of periodontal health in terms of restorative margins that we need to work on marginal fit, we need to work on surface finish, we need to work on the contour of the restoration, what we are giving. Now, that the bread and butter is fillings and endodontic treatment. But I say the bread and butter of dentistry is periodontal health. Periodontal health in terms of dentistry. Periodontal health in terms of working for dentistry. Periodontal health in terms of any branch of dentistry, but respecting the periodontal health. If we don't do it, we cannot do dentistry. We cannot be a good dentist. We cannot expect our patients to come after 15 years and say, Doctor साहब क्या filling करी थी आपने? 15 साल हो गए जो filling आज तक नहीं गई. Look at this photograph. Now this filling has been done in the interdental area and it has led to the punched out interdental tissue. And the patient comes back to you after 3 months and tells you, Doctor साहब, I am not comfortable here. I want to put something into my tissue because it's irritating me. Next photograph, please. This filling done by the patient, but a lot of interdental space is left behind and can lead to food infection, and the patient is not comfortable having done this filling by any dentist. A punched out, interdental area giving rise to a fistula because the filling is not done properly and the tissue has come out and the patient is not at all comfortable. Another filling done by a general dentist which led to food infection in this patient. Another filling done by the patient which led to, the loss of bone. This is how the patient responds when you do such fillings. Comes back to you after a few months. Doctor साहब, क्या काम किया आपने? Doctor साहब, but we want to tell you that competence is very important. Acumen is very important. It is not important that you ratify the things, you ratify periodontology, but you should be mentally a periodontist, so that you practice general dentistry in a way that people remember you for ages and ages together. Even after you go from this life, people remember you, wow, what a great dentist he was. Great fillings done by great dentists. Next, please. Why are you in a hurry, Ria? Using these bands is equally important to maintain the interdental tissues along with the wedge during the fillings. But I wanted to know from all of you, which wedge out of these two is better for periodontal health? Go back, please. Which wedge out of these two is better to use for periodontal health? Anybody, doing general dentistry here? Sectional band. Lot of chocolates here to that young lady who raised hand. Yeah, and the front row. Front row, please. Yes, sectional bands we have been using in general dentistry and they are perfect for doing fillings. But you have to know how to use them, how to use the interdental wedge. That slide shows a correct way and an incorrect way to use these bands and the wedges, please. Another case, filling done about 5 years ago, periodontal tissues and the filling in perfect harmony with each other. Another chocolate question. What abnormality do you see in this case? I have got 280 chocolates with me. Please distribute. Please distribute. No. I am full of chocolate. I am with full of chocolate. Distribute everybody, please. Yeah, overhang margins, perfectly fine. And a few examples of overhang fillings which has caused damage to the periodontal tissues, which has caused damage to the alveolar bone, which has caused damage to the supporting structures of the teeth. As you rightly said, periodontist is the one who takes care of the periodontium because that is the lifeline of dentistry. Now, again, I say it is important to know the subject, but it is important to be काबिल, क्योंकि कामयाबी तो साली झक मार के पीछे आएगी. And a big round of applause for such people who have been कामयाब in their lives. Next slide, please. I may not be, carrying such pictures, all the pictures for everybody, but all my mentors, if I am missing any photograph, please forgive me, sir, because I couldn't lay my hands on pictures so fast because Baljit told me that we are falling short of time. Sir, please reduce your slides. Thank you very much. Now, I must tell you that periodontists are one of the best implantologists. We are practicing implantology in our hospitals, in our colleges. Periodontists are dedicated because periodontists are the one who know what is the keratinized mucosal width. He knows what is the mucosal thickness. He knows what is the supracrestal tissue height, and he knows what are the peri-implant bone thickness. Because we are pally with these terms, therefore we know how and where to place the implants, how to maintain the aesthetics. Now this slide shows an implant done by a general dentist, but he didn't take care of, the aesthetics of the patient. And this implant has been done by a periodontist. But once we do the implants, my dear friends, it is our ardent duty as periodontists, my mentors, my colleagues, I would like all of you to teach our students as to how to maintain the implants, Because if we don't teach our students how to maintain the implants, we land into a number of problems. We teach our patients, we teach our students placing the implants right and left. But peri-implantitis is one thing as periodontists, which we must teach our students, which we must teach our colleagues. Now here you can view that a 3-unit bridge has been given, but there's a lot of bone loss. As you can witness, in the OPG, a lot of bone loss in both the implants. Next, please. Again, when you see this slide, the bridge has been fixed, but the operator has not taken care of the cement, which is there at the neck of the implant. Good morning, Dr. Sir. At the neck of the implant, you cannot go with that, and you can imagine that this implant will go for years together. You have to take care of implantitis. Anybody who knows this person? Elon Musk. I drew Tesla when I went about a few years ago. This is Elon Musk. He was very when he started his career that I wanted to be an entrepreneur. He wanted to be an entrepreneur, and therefore he, gave his dormitory in rent when he was in the college because he wanted to earn money out of it. So this man has attained what he wants, and my suggestion to you is that you have to think periodontally to be a millionaire, to be successful, because periodontal state of mind is one which will make you a successful dentist, as bone is no longer the only issue. Tissue is also the new issue. We must understand that. If somebody says you that peridontist है हम, flower नहीं, fire है.
तेरी झलक शर्फी श्रीवल्ली नैना मदक बर्फी तेरी झलक शर्फी श्रीवल्ली बातें करे दो हरफी.
A big round of applause for my postgraduates who have helped me with this presentation, and my staff members and the postgraduates standing here. Thank you very much for listening. Thank you very much if, I have not spoken properly because of my condition. Thank you very much for being so patient. Thank you. Any questions, I would welcome.
Thank you so much, sir, for the wonderful lecture on the topic, let us explore the dental world from the eye of periodontist. And it's nice to see that you have touched on all the aspects and the importance of perio as well. And I think we are all blessed to have a legend, Vikas sir, with us. I think your gracious presence today has blessed all of us who have come for this ISP PG connection. I request everyone, please stand up and give a big standing ovation to our one and only Dr. Vikas.
Thank you very much. Thank you.
Thank you. Thank you.
Thank you.
Any questions, please? Thank you, sir.
Thank you very much. Now I would like to request the chairpersons to kindly felicitate our speaker.
Like this. Thank you very much. Thank you. ये रखना पड़ेगा आपको. Thank you very much. मुझे छोटू बोला.
Now, I would like to call upon stage Dr. Neeraj Deshpande, sir, to state the chairpersons.
We have with us Dr. Anil Singla, Director, Himachal Dental College, Sundarnagar. So I would request our organizing chairperson, Dr. Baljeet sir, to kindly felicitate Dr. Singla with a bouquet as a token of respect. Thank you so much, sir, for coming. Thank you.
Take a minute. Thank you very much. The Indian Periodontal Society management members, the organizing committee for the PG convention. We are really grateful that they have given this opportunity here for Dr. Vikas to present. This is one of the happiest days of my life. After 3 years in the same league which he used to be before the accident. Thank you very much. Vikas, you are back where you belong to. Thank you.
And I'll add to what Anil sir has said. So we haven't given any opportunity to Vikas sir. He is one of the most prolific speakers we have in the Indian Society of Periodontology. He deserves it. And I always pray that I want to see him back on the stage on his feet. God bless him with good health always.
So now moving forward, in countering the periodontal, it is essential to consider the efficacy of given antimicrobial as role positive factors governing to its use. The chemical block control using antimicrobial mouthwash as an adjunct is therefore a very effective and practical method to shed some more light on the same. We would like to start our next session of the day on the topic pragmatic approach to the use of antimicrobial mouthwashes and Indian perspective. To begin with this session, I would like to call on stage our person, Dr. Ashish Kumar sir. Dr. Ashish Kumar sir is the alumnus of Bapuji Dental College and Hospital Davangere. He is currently working as professor and head in the Department of Odontology at Dental College, Regional Institute of Medical Sciences, Imphal, Manipur, India. We welcome you, sir.
Now, I would like to call upon stage the second chairperson of this session, Dr. Neeraj Deshpande, sir. Professor Neeraj Deshpande, sir, has completed his master's in periodontology from prestigious Manipal College of Dental Sciences, Manipal, currently serving as a treasurer of Indian Society of Periodontology, MBA in Administration, postgraduate diploma in medical law and ethics from National Law University, Bengaluru, PhD in education from Navratna University. He has more than 75 publications in national and international journals to his credit. We welcome you, sir.
Thank you. Thank you.
I would like to request the chairpersons to kindly introduce the speaker of the session, Dr. Vishakha Grover, ma'am.
Dr. Vishakha Grover, the scientific chairperson for this PG convention. Everyone knows, I think she doesn't need an introduction, but still, I would like to tell something about her, that she is working as associate professor in the Department of Periodontology at Dr. Harvansh Singh Judge, Institute of Sciences, Punjab University, Chandigarh. She graduated from GDC Patiala in 1997 and did her post-graduation from GDC Amritsar in 2001. Did her PhD from SGT University, Gurgaon in 2021. Has published almost 83 scientific papers and 10 e-books of specific postgraduate interest topics. She's closely involved in recently published national guidelines document for the management of periodontal disease in diabetic patients. She has been granted an approval from the Department of Science and Technology of India research project. So the stage is totally yours, Dr. Vishakha, for next whatever time, because you are the person who has to decide.
Thank you so much for such kind and lavish introduction. Very good afternoon to all of you, and hope all of you are enjoying the scientific deliberations so far. And before I start my lecture, it's a disclaimer. It's a privilege to share this podium where Dr. Vikas has just, walked upon. But with folded hand, I say I may stumble like a kid after him. So please consider that. So sir has given a very, very wonderful definition of periodontics. With that, if we say all of us being periodontists, it brings us a unique position to us, unique responsibility also, where we, apart from any other specialty surgeons or dentists, we have a much longer association and rapport with our patients. As all of you know, we have to have our patients put into the maintenance phase for long time oral health. So I am going to touch upon a topic which is very important from that standpoint, which is pragmatic approach to the use of antimicrobial mouthwashes and Indian perspective. Now, periodontal disease, the facts and figure, and I think all of you must be very much versed with the first line. Periodontal disease is one of the most widely prevalent disease, probably the first liner to most of theses and LDs, whatever you put across in your MDS time. So prevalence of disease is ranging so much that almost more than 50% of the worldwide population suffers from periodontal diseases. In India, essentially, we have it as a major public health disease burden with periosystemic connected to it. Now the term is appearing on most of national policy documents, the oral health and such like things. We have started noting it down. Now, from a very recent systematic review, which has come in 2020, if the pooled on prevalence of gingivitis is around 50% and up to 70% in the urban population, that means us, right? So, and the major cause related to this disease, all of us are much substantiated with this is dental plaque, which is the major and the standalone cause to periodontal disease. How do we manage such a disease? The current standard of care, I think all of us are acquainted, generally the anti-infective approach, scaling route planning, probably surgery in some other cases, but mainly supra and subgingival plaque control. And once we complete that for our patient, then the most essential phase of the therapy starts, which is self-performed oral hygiene. My students must be able to relate. I just give one statement when I part with my patient after active treatment. See, I was accountable for your teeth and the hygiene of teeth as long as you were in my clinic for this 1 hour. And the moment you step out of my clinic, probably it is your accountability. And that's really, really true, because we can cater to the oral health during that time when they are with us. And then it is the patient's teeth, patient's accountability. Most of us put our results also on this stake, that how well you maintain your plaque control. Saying that, that does not relieve us from the periodontist's duty. Actually, patient being a lay person, it is our duty to make him aware, equip him with the knowledge and help him in that decision making how to control plaque. So along with scaling route planning, nowadays most of antimicrobial agents have been known as to augment the effect of mechanical plaque control. They tend to enhance the benefits of scaling route planning as well as the surgical performance. And these are the probably most commonly seen antimicrobials what we use: doxycycline, penicillins, ciprofloxacin, onadazole, augmentin. These are few drugs which are used systemically. Apart from that, many chemical plaque control agents in the form of antimicrobials are available. Now, what is the rationale of using antimicrobials along with the mechanical therapy? Anyone? Those are slide shows, but anybody? Why do we need chemical plaque control? Cannot substitute it with the mechanical plaque control, the general tooth brushing, but essentially it tends to augment the performance of the mechanical plaque control. Why we need to depend upon this? Because plaque control by brushing is not really that simple as it appears. It is dependent upon a lot of factors, mainly on the dexterity of the patient, thoroughness the patient performs. It's not really with the brush design or the type of dentifrice, but how well the patient is able to clean up the supragingival plaque control. So to nowadays, many antimicrobial mouth rinses have been advocated. The concept of chemical plaque control may be justified as a means to just complement the efficacy of mechanical plaque control. Principle, why for picking up an antimicrobial as a chemical plaque control agent, what we need to look in. Number one, it must reduce the oral bacterial count. Number two, it must slow or reduce the development of plaque. It should also work against the mineralization of plaque. It can also target that a very pathogenic plaque may be converted into a non-pathogenic or a lesser pathogenic. This dimension yet needs a lot of research. Yes, we are working on targeted antimicrobials, but so far today where we stand, we are standing on the basis of the chemical plaque control agent, which are going to give a total reduction in the oral microbial flora. So how do we use these drugs? Professionally, of course, as subgingival irrigants, varnishes, etc. But when I come to home care or self-care, you can see these toothpaste, mouth rinse, irrigants, gels, varnishes, or chewing gum. And if you compare all these portals, probably it is the mouth rinses which take the major lead, which are the mainstay. Why so? I think mouth rinses are the most widely used chemical agents. Any reasons? It can pass through, yes, and they are pretty convenient to use. You really, that's how we know them, that you really do not use many technical knowledge to use it. So its technique is not really difficult to master. They are available over the counter, cost effective, and they definitely augment the mechanical plaque control. That's how we know the use of mouthwashes. Now we are going to dig little deeper to this. That is why this presentation comes, the pragmatic approach. Now I'll just take on to why it is important to look into which mouthwash to use, how to use, when to use. Probably over-the-counter drugs are available, but mouthwashes, if you say, range mainly into two categories. One are cosmetic mouthwashes, other are therapeutic mouthwashes. Cosmetic mouthwashes are over the counter. Over the counter, I hope everyone is aware. You can just go to the shop and ask and you get the medicine. The other ones are the therapeutic mouthwashes, which needs a prescription. And what happens in India is why I have said an Indian perspective. In the lack of awareness and availability of so many mouth rinses in the market, patient is really not aware what he is getting in that particular stuff, right? So when I say any prescription, but therapeutic, they may contain active agent. These are those mouthwashes which have certain antimicrobials, and we cannot intend to use antimicrobials without any rationale or reason. Patient may harm his health more than by using a wrong mouthwash. And probably if you remember, sometime back there was a lot of buzz in media some 2 years back, if any of you are aware, regular usage of mouthwash can cause diabetes. Has anybody heard? 2017, there was a paper in US and it stated that regular usage of a mouthwash in a routine go may predispose the patient to diabetes or may worsen the diabetes. So why so? The study was pretty biased, but why I am bringing that in context, the decision making has to be apt. The availability is so much that patient really does not know what he is getting. It is important for us to make the patient aware, and this decision should go by the guidance of the dentist. Now, with my discussion in today's section is limited to the therapeutic mouthwashes. We are talking of the antimicrobial usage in the mouthwash. So where they are clinically indicated, one is in general to maintain oral health and hygiene. The second most important clinical indication is before and after certain dental operative procedure, maybe pre-post surgical, or for the patients who are on orthodontic treatment, where the patient's mechanical plaque control is compromised. So it is important that it needs to be augmented with chemical plaque control. Some of the indications, oral mucositis in immunocompromised patient. Now these patients, they have more vulnerability to infections. So with lack of salivary, patients who are undergoing radiotherapy, chemotherapy for a lot of head and neck cancers, they may have reduced saliva in their oral cavity and the mechanical plaque control is limited, efficacy is limited. So here you need to support these patients with the chemical plaque control. Fungal infection, halitosis, again one very important and a common cause for the use of mouthwash. Again, patient may go to the drugstore and get a mouthwash for improving his breath odor, just that. Apart from maintaining the chemical plaque control in the oral cavity by an antimicrobial, what all a compound needs to have if it is to be used as an ideal chemical plaque control agent? We need to, it should be safe oral tissues at concentrations and dosages recommended. Number 2, it must exhibit substantivity. Substantivity, anyone? What is substantivity? Staying on place, or it is probably the ability of a compound to get adsorbed onto the surfaces, not absorbed, adsorbed, AD, not AB. Important for postgraduates to know. Adsorbed onto the surfaces and to be released from there on in slowly released. That actually gives us the dosing time, how many times we are going to use the mouthwash in the oral cavity. Third is, it must not prevent it must not cause development of resistant bacteria, and it must inhibit the calcification into the calcification of plaque to calculus formation. Now, with all this background, we know what all compounds we have in use today. Lot of molecules are present with their essentially merits and demerits to those particular molecules. We have some time-tested agent, essential oil, rinses, povidone iodine. Povidone iodine is a very effective broad spectrum antimicrobial, but the only issue with the iodine is it lacks substantivity. Probably you may relate to it. The use of iodine during the procedure is far more common than recommending iodine for long-term plaque control, because the time duration is important here. So, molecules, apart from that, we have certain oxygenating agents, we have CPC, we have triclosan, we have some antibacterial enzymes, and the usage is not really far and wide. What we have depended for all these years on, this is the current standard of care. I believe all of you know what this compound is, how many long it has been in the history. Chlorhexidine, this is known as the gold standard or the standalone agent in chemical plaque control. Why so? The hexidine has an outstanding property of substantivity. It stays on the surfaces, released later, and maintains the plaque control. That gives us a regime of twice use of antimicrobial in the oral cavity. Apart from that, short-term and long-term reductions are up to 70 to 80% of the plaque reduction with chlorhexidine. And over a use of 6 months, probably this drug has never been documented to cause any kind of bacterial resistance, which is a big plus to the drug. So that is why chlorhexidine is considered as the gold standard. Also, being gold standard, there are certain issues which we are familiar with, but over last 60 years, we have accepted this drug along with these common complications. What are those common complications? The most important one, staining of the teeth. Number one, probably in almost in each case where you use hexidine for a long period of time, say more than 2 to 3 weeks, it tends to form dark brown or blackish stains on the teeth. An increase in the calculus deposits, especially supragingival, and alteration in the taste perception. And apart from that, you may also come across sporadically, these have been reported. There are chances of desquamation, there is chances of ulceration, some parotid swelling cases and all. So these are the common complications to chlorhexidine. Now, drug has been the standalone in chemical plaque control, served the purpose well, has been accepted by the clinicians and patients also, with all these common complications. The reason to that is, any guesses? Why the hexidine has been a gold standard for all these years? There is a simple reason to it. Probably we could not develop or find any drug which could work at par with this or give us an edge over it. So probably today we stand on this time to pose this question in a organized, structured way. I am going to take you to, is there any formulation available which is comparable or superior to hexidine? Anybody? Have you ever come across any drug which is comparable at its efficacy or superior to hexidine? No? Okay, let's dig deeper. Octanidine. Anybody heard of the name? Anyone in the hall who is acquainted with the drug? No. Great. Great. Happy to hear that. Now we need to know this. Why I'll just introduce and we'll get to the drug in every nook and cranny of the drug, right? This is an antiseptic agent originally described in some 30 years later than chlorhexidine, 1980s. A cationic surfactant that belongs to bispiridine class, very close to hexidine. Structure consists of two non-interacting cationic rings separated by a hydrocarbon chain, a broad spectrum activity, minimal contact time. wider pH range. It works from 1.6 to some 12 pH, right? And lower toxicity. Lower toxicity because the generally potentially toxic agent is created by the metabolism of drug, which is not there in this drug's case because it lacks those chemical groups basically which tend to the formation of that metabolite. How it acts, the way is very close to hexidine, cationic agent working on to the negatively charged lipids of the cell membrane, getting into the phospholipid bilayer, disrupting the regularity, leading to osmotic changes in the cellular permeability changes, so osmolality of the drug changes, of the cell changes, thus leading to the cellular lysis and cell death that causes the bacterial cell death. This is how it interacts and which is almost in sync with chlorhexidine because that's also a cationic agent, right? Now the clinical evidence. Now this is the paper we have come up, these four periodontists from India, of course including me, Dr. Gopal Krishnan, Dr. Ashish Jain, Dr. Jaydeep Mahindra. We took up this assignment 2 years back to look into the literature systematically about the clinical efficacy of octanidine and comparing it with the placebo or with the use of chlorhexidine. Why systematic reviews? Because basically drug yet needs to be worked upon a lot, not much of RCTs in India. Probably we by the end of this discussion, probably I will say that we should go for RCT on this. Drug is being marketed in some of the European countries now, fortunately available in India also. So we actually took up this analysis to get to know if there is something which can work at par with the hexidine. This was the question. And the findings were really interesting and amazing, and to my surprise as well. So that's octanidine inhibits plaque formation up to 93% and gingivitis up to 70% when compared to placebo or to the hexidine. And it was considered as the most effective plaque control agent in terms of reducing the salivary load of bacteria. And for this systematic review, whatever articles I could include for analysis, out of all those studies, there were 7 studies where the compound was rated better than hexidine, with 1 study where it was comparable in efficacy. So that actually led to more of interest into the drug. And there are few studies I want to showcase here for your knowledge, since I'll talk why at the end. So first study I want to showcase here is the dose winding study for octanidine, where the drug has been used in gingivitis patient to determine what dosage of the drug is most effective. So 3 concentration, 0.01, 0.15, now 0.1, 0.15 and 0.2. And when these were compared, there was statistically no difference in the clinical efficacy at the higher concentration. So 0.1% octanidine was considered as the preferred choice. Greater than sustained antimicrobial effect. Here, the drug was used in orthodontic patients compared against gold standard PVP, iodine, and the results showed that during 5 days of usage, octanidine was the most effective mouthwash in terms of reducing the salivary microbial load. If you have a close look, this is the total bacterial count where the drug has preferentially been better than the rest 3. This is the count against lactobacilli, where almost all the compounds were well except for placebo. And this is against the Streptococcus mutans. Here again, octanidine performed better than hexidine and povidone iodine. This was again comparative clinical study. Again, the drug has been compared to hexidine in combination with scaling and root planning, and octanidine was found to be better than 0.2% chlorhexidine. Now, this one is particularly interesting study from Indian, based on Indian population only. If you see, this is the comparative graph for those 2 drugs, octanidine and hexidine. at baseline and 21 days for plaque index, gingival index. And if you see the drugs, they are working almost at par, proportionately the same amount of reduction. Where you see the difference is this section, staining. This is the staining after 21 days by hexidine, and this is the staining observed in the case of the uses of octanidine. So that is why the drug needs attentions from all of us, so that it can be critically analyzed for better usage. There are a few practical implications which came from this data. One, there is fast action. 1 minute contact reduces 99% of the bacterial microorganism. Prolonged action, the drug's action inhibits plaque formation over a period of 7 days. Over 7 days, I really don't intend to say 7 days patient is not supposed to brush, but during these testing conditions, essentially the drug performed better in the absence of the brushing. Third is a strong action. Strong in terms of octanidine could resolve the a preformed plaque prolonged duration, approximately 10 days old plaque was lysed with the usage of octanidine. This is again one anti-adhesive activity study, probably where it reduces the adhesion of Streptococcus sanguis to the enamel. Now the safety, this was about efficacy. Now the other arm, where we need to refer or weigh the drug usage is basically safety. The drug is supposed to be less cytotoxic than hexidine. All the references has been there. I'm sorry for the poor display with the resolution. I believe this is not visible, but all the references are there. You can be in touch. If anyone is interested in the drug, you can have all the literature from the published article and from me also. And the drug is supposed to be little selective to bacterial cells because it is supposed to interact with the cardiolipin molecule, which is a constituent to the bacterial cell. So this is known to spare the host cells from the cytotoxic action. And so far, again, no bacterial resistance observed. So this was important. Therefore, for the clinical usage, of course, all the uses what we mentioned at the outset stand true for the octanidine. And how the dosage and administration, again 15 ml of the drug for 30 seconds, 2 to 3 times a day. Same instruction as for hexidine because the drug is almost same or the better substantivity. Now summing it up, I believe if we compare both these two at a scale, anti-plaque activity, bacterial anti-adhesive activity, sustained action, the drug is almost at par or better. Cytotoxic effect is much lesser. Antimicrobial effect is prolonged. The range of working is far more on a wider range of pH, the drug is effective, and bactericidal action in lesser time. So essentially it gives a lot more reason to look into the drug in far more detail what we are going. So summarizing, this is a small short presentation just to bring your attention to the drug, since you people are largely the research resource for India. I will say MDS gives you the best time to do research. So a lot more trials actually are needed. Lot more work is required to look into the drug. So optimal use of mouthwashes could reduce the considerable health and economic burden if we use them optimally. Hexidine has been our favorite and continue to be so, the most accepted one. But essentially, we need to look out for more alternatives with lesser side effects. Maybe they can give us better patient outcomes in certain specific clinical conditions. And effectiveness of octanidine-based mouthwashes were either superior or comparable to other available mouthwash formulations. Now, in limitations to the drug where we stand today needs far more research and needs lot more activity into the clinical practices, whether it has to be used in combination with the well-controlled call of the hour. And on a personal note, I would like to share, because many of my patients had been using this drug, because drug came into market for a while, and they came back to me for the same molecule, especially the orthodontic patients, children. The compliance was far more better in octanidine. For a while during COVID times, the drug wasn't available. People had been coming back to ask for the same mouthwash. So that is why I took this opportunity to showcase the new molecule to you. A big thank you for patient listening from my side. Any questions or any need for literature, you can contact me on my email. And I would like to thank the chairpersons for the kind attention to ISP organizing committee, and a big thanks to Abbott who for their vision, for striving for better, for bringing out or looking into newer molecules to support scientific community to bring out this evidence. So that's all from my end. Thank you very much. Any questions, you are most welcome.
Thank you so much, ma'am, for this wonderful session. I would like to request to the chairpersons to kindly felicitate our speaker. Now, I would like to request Dr. Abhay Kolte, sir, to please come on the stage to felicitate the chairpersons.
Now, moving to the last segment of today's session, we'll be having a panel discussion in 5 minutes.
Having a good discussion is like having riches, and a good discussion increases the dimensions of everyone who takes part. It's time to begin with the last and most awaited session of this day, which is Symposium on Periodontal Clinical Research Method, Ways and Means to Accomplish Better Evidence. I feel immense pleasure in inviting some of the stalwarts of periodontology to share, discuss, and exchange their view on the same. Now, I would like to call our first panelist, Dr. Anirban Chatterjee, sir. He is the current president of ISP. He was the former vice principal, professor and head, Department of Periodontics and Implantology, the Oxford Dental College Hospital and Research Center, Bangalore. We welcome you, sir.
The next panelist I would like to invite on stage is Dr. Abhay Korte, sir. He's professor and HOD in Department of Periodontics, VSPM Dental College and Research Center, Nagpur. He's currently the president-elect of ISP. We welcome you, sir.
Our next panelist is Dr. H.S. Grover, sir. He did his post-graduation in periodontics from the prestigious King George Medical College, Lucknow in 1988. Having served 4 terms as an executive member and 2 terms as vice president, he was elected as the secretary of the ISP in 2019 and continuing since then. He is the presenter of more than 100 scientific papers. Sir has more than 145 publications and contributions in 7 books on various topics of periodontology. We welcome you, sir.
Next, I would like to invite on stage Dr. Anil Melat, sir. He's currently working as principal and professor and HOD in Department of Periodontics and Implantology, Mahe Institute of Dental Sciences and Hospital, Mahe. He has been awarded Most Proactive Senior Academician in Periodontics 2019. We welcome you, sir.
Our next panelist is Dr. Subhash Chandraat, sir, Associate Professor and Head, Postgraduate Section, Department of Periodontics, SCB Government Dental College and Hospital from December 2012 till date. BDS, SCB Dental College and Hospital, MDS, Government Dental College, Bengaluru, many national and international publications and presentations. His major topic of interest is novel surgical techniques in mucogingival surgery, interdisciplinary periodontics, soft and hard tissue augmentation around implants. We welcome you, sir.
For moderating this session, I would like to request Dr. Vikram Balagna, sir, to please please be present on the stage. Sir is professor and head of Department Periodontology and Oral Implantology at Indraprastha Dental College and Hospital, Sahibabad, Ghaziabad, Uttar Pradesh. He did post-graduation from prestigious Punjab Government Dental College in Amritsar in 2002. We welcome you, sir, on the stage.
Thank you. First of all, I would like to thank the organizing committee to please give me for giving me the opportunity to moderate this session by our elite panelists of periodontia. Welcoming the panelists on the dais, I would like to wish a very good afternoon to all the friends and students. As you, today we are going, it's a pleasure to be here amongst you all. It's a pleasure to be here amongst you all and have a deliberation on this much important topic of periodontal clinical research methods, the ways and means to accomplish better evidence. Our field of periodontology is a very young field. Having said that, I mean that our field is much younger than most of the other fields or specialties of dentistry. By this, we mean that we are growing at a much faster pace, whereas other fields have become quite mundane and typecast. That's because there's so much new things which are happening in our field. So much research is being carried out in our field. So much new techniques and materials are being
brought about in a field that we have a huge potential to grow. We have huge potential to grow and do research on. Periodontal research has witnessed a tremendous upsurge in the last 2 to 3 decades due to the new innovations in techniques, methodologies, and material sciences. Research also being a very integral part of our MDS curriculum. All of us being postgraduates spend good 2 to 2.5 years of our course in doing research. We all hope also that it gets published in a good journal, don't we? But then sometimes at the completion of the research work, accepted. In planning, had there been some mistakes in the parameters which we had chosen? So sometimes it is unclear, and then we have to go for journals which were not our first choices. So today we are gathered here to have a deliberation on this much sought after topic of periodontal clinical research methods, where our elite panelists would guide us on how to plan a study, how to execute them. And when you hear them tell about the respective requirements, you would understand what lacunae we might be facing while doing our research work. And by listening to we would be guided enough to how to alleviate those lacunae and to see that we have a good case research at the end of our thesis. So periodontal research is presently being focused on the evidence-based research. The evidence-based approach helps in bridging the gap between the science to clinical practice. Evidence-based research can be defined as the use of prior research in a systematic and transparent way to inform a new study so that it is answering questions that matter in a valid, efficient, and accessible manner. The various characteristics of the study which we should be having in mind while planning a study are: value. Is the proposed study worthwhile? Does it add true value? We need to question, does the research study which we are planning, does it fill in the evidence gap? If it has been analyzed by previous systematic reviews which have been done, does it meet the relevant perspectives of the end users who are the patients, the clinicians, or the caregivers? Does our study which we are planning, does it take into account the unbiased and trustworthy knowledge of the existing evidence, the statistical methods which we would employ, the cost of research, as well as how to report our findings? Apart from these, the other strong determinants which are necessary for a good research is the access to funding, access to relevant technologies, and also it all depends on the ability of the researcher also. Keeping this in mind, today's topic, today's panel discussion has been tailored to meet the needs of all the postgraduates, may they be from the first year or second year or the third year at the different stages of their research. So today's deliberations will help us recognize the lacunas and help us alleviate them. I would like to inform the audience that we have among us Dr. Anirban sir, who would be apprising us with his expert views on conducting the clinical trials. Dr. Kolte sir would be enlightening us to conduct a study on implant-related research. Dr. Grover sir would acquaint us on conducting a study on periodontal microbiology. Dr. Anil sir will share his deliberations on conducting a study on biomarker assessments. And Dr. Subhash Raj sir will conduct a study on, will guide us how to conduct a study on periosystemic interrelationships. So going forward with the session, I would like to put the first question to Dr. Anirban sir. Sir, if a researcher wants to plan an interventional clinical trial, sir, as many of us plan to do so during our postgraduate training, what all considerations should be kept in mind while planning it, sir?
Thank you, Palagna. So basically, research is nothing but a systemic approach to the truth. What you're going to get out of your research, whatever clinical, if you're talking about. Now, perio being a clinical subject, if you're doing a clinical study, preferably it should to discover the truth. So hence, we should be more systemic in our approach. The approach should be more in a systemic way, like systemic in planning, systemic in designing the study, systemic in conducting, systemic in analyzing and reporting our periodontal research. Report in the sense, in the publication wise. What you need to see when you're trying to do the research in the initial stages is whether it is cost effective, whether it is ethical, whether you'll be able to complete the study in the given duration of your PG course, because 6 months is, you have to submit your synopsis, and 6 months, that means it requires at least 2 years before you can do, correct? So eventually what I'm trying to say is all these things should be taken into care. Then what is that you like to do? What is that what you like to do? In the sense, what is your expertise you want to like to do? Let us take somebody would like to do with, I want to do on a PRF. So whether you want to do on PRF, whether your guide is also wants to do on that, whomever is guiding, whether your guide is telling you to do something else, which you might not be much want to do on that particular subject. I'm just giving you a hint of that. So that should be one thing. Then the biggest thing is the sample size. Sample size is very, very, very important. So what we do, we just go to a statistician and we just give them what should be the sample size. You have to be sitting with the statistician, and that statistician is not a periodontist, doesn't know. You have given one or two studies or research papers you have sent, and they have just read that and they have told you it should be, each site should be about 15 in number. But to get the power of the study to 95, it might be 15, it might be even 10. It can be even 10. Okay. The power of the study, if you require 95 power of the study, then what is the actual requirement? That is what is more important when you're taking a sample size. Okay. Then if it is 15 in each group, if it is 15 in each group, that means you have to do 18. Why? Because there is a chance that 3 of them might not turn back. 3 of your subjects or patient might not turn back. So it should not go imbalance. Correct. And so this, you need to first of all understand the research methodology before you start with your synopsis. Research methodology is itself, you need to go at least for 10 to 15 days training by a good person who knows about research methodology. Might be a college should have a research methodology classes, etc. Then periodontal research, what is the unit of measurement what we see? What is the unit of measurement we see? We see individual sextant, we see individual quadrant, or we see an individual's mouth. That is the unit of measurement. In this, the results always differ depending on this, on what you're taking, what unit have you taken, whether a sextant or a quadrant or an individual mouth or only an individual tooth. So taking that into being, the variation in this respect boils down to inconsistency as the results are reported. Because in periodontal parameter like BOP, then PPD, CAL are assessed pre-intervention and post-intervention. That's what we do in a clinical trials, in a clinical surgeries, or whatever we are doing in research. So it boils down to pre-intervention, how much it was, and post-intervention. Correct? So the examiners or assessors who are doing this particular job, pre and post, should have a proper inter-examiner variability. They should know exactly what should be, how the measurement should be done. In the sense, guide is the gold standard for your taking the measurement. You should be able to, the guide should, there should not be variable 0.08%. There should not be variation between you and the guide. Guide as the gold standard for measurement between you and your guide by 0.08%. So this needs to be taken into account. Okay. And then it should not be that once the result comes, it should not be GIGO. Garbage in, garbage out. Just you got something, it has come in, you got something, and it is out. That's all, whatever it is. So research should be tactically, it should be done in clinical research in a way which needs to be understood. It's not that something has been given to you and you don't like the topic, then ethically, again, I was just speaking to Ashi also, a person ethically, you give somebody a non-vegetarian, vegetarian person, a Jain, somebody, you are doing something with bone grafts, which is not ethical. Or a patient is who is a vegetarian, doesn't know that you are giving an ox bone graft. So those things ethically you have to see what it needs to be done. Then at times, like our research are translated into our qualitative data into a quantitative data into a qualitative one. Example like cal. If cal can be measured in mm, that is quantitative. It should be respect the data because it is quantitative. It don't convert that quantitative into qualitative. Okay. So these are the points which you need to take up before you submit your synopsis. First and foremost, you have to know about the subject well, what you want to do. You should like it, and you should sit with the statistician in a proper way and make that person understand what is that you want to do with the idea. Okay, thank you.
Thank you, sir. So considering that periodontal pathologies have immunoinflammatory factor to it, and recent literature has been finding a lot of interrelationships between systemic conditions and periodontal pathologies, I would like to ask Dr. Subhash Raj sir to please guide us how to conduct a study on periosystemic relationships. Please.
Thank you, Dr. Vikram. Actually, this is planned for the postgraduate students, how to proceed about the research. So if I am a postgraduate student and as my guide is Dr. Vikram, and he has given me the topic of periosystemic. So now I have to think on what basis, what is my research question on periosystemic? What exactly the literature available on periosystemic research, what exactly I have to do. So if you go back to the literature on periosystemic, definitely it is one of the very important topic on clinical research on periosystemic link. And till today, if you go to the studies, almost 1/3 studies are on the periosystemic. So now question is what exactly I have to do regarding the periosystemic. So question is there a link? Is there a causation between perio and systemic? Are there syndromes? Are there syndemics? So these are the questions I plan for. So whether I'll think of that there is a link, so that should be my question or the hypothesis, or there is a causal relationship. So if in that way, you will find there are 57 systemic diseases that are associated with periodontitis. And if you find true literature, there are almost 29 landmark studies that has been done to associate periodontitis with systemic disease. So, I mean, the studies, you may say cross-sectional study, you may say case control study, or you may say longitudinal study. But the literature suggests that only the association between periodontitis and systemic disease is with cardiovascular disease, the diabetes mellitus, and the advanced pregnancy outcomes. And these are upheld in systematic reviews, because that is what we have to look for. What is the basis of my study? And then is what is my question, my research question. So now, whether I will provide that periodontitis is the link between cardiovascular disease or diabetes, or I'll go for a causality. I mean, the clinical research on periosystemic, whether periodontitis can cause diabetes mellitus or the advanced pregnancy outcomes. But if you search the literature, the interventional study never inform of causality between periodontitis and systemic disease. So there is a need for interventional studies. If you want a good dissertation topic on periosystemic, you have to do interventional studies on periosystemic, like any you take either cardiovascular disease or diabetes mellitus or adverse pregnancy outcomes. So if you can have, but it is very difficult to do interventional studies on periosystemic. So if you are in a government setup, maybe it is possible. Otherwise, at least you can plan for an observational study with good sample size, a longitudinal study, and the diseases that are not at all proved as the association between periodontitis and systemic disease, like respiratory or chronic kidney disease and all this. So that is what we should have a research questions. And these are the three research questions, either descriptive or between the causation or the relationship and the comparison. So these are the research questions on periosystemic. So based on this, I'll plan my study on periosystemic, or I mean any clinical research, intervention study, or observational, or case control, or prospective, or retrospective core. So that should be the thinking of any postgraduate students when the guide gives the topic that you do on periosystem. So that should be the plan.
That's right. Thank you, sir. So even if we don't take up the periosystemic relation as this thesis dissertation, we can always take it as long-term studies, and which will be very beneficial to the subject of periodontitis linked with various systemic conditions. Next, I would like to pose a question to Grover, sir. Considering that the periodontal disease is of a polymicrobial nature and the complex interactions occurs between the various pathogens which are present, how would you, what all points should we keep in mind for a study based on periodontal microbiology?
Thank you, Dr. Vikram. If I may, I would like to point out right at the very start that, in fact, periodontal microbiology remains the keystone of the research. And if we see the 5 topics, even today, biomarkers, microbiology, periosystemic again is microbiology in a way, implant related research, majority of it would be somehow associated with microbiology, and clinical trials is of course how the reporting and all those goes on. So periodontal microbiology, right from the beginning of the periodontal research, if we trace the history by about 100 years, very briefly, it started with William Hunter and Miller, somehow relating the microorganisms with the systemic disease. So in a nutshell, they had already identified that periodontal disease is a bacterial disease, but it was an on and off situation for the next 120 years, because down the next 50, 60 years, the focus shifted from the microbiology to occlusion and parafunction. as the main culprits for periodontal disease. So as periodontists, I believe that 3 landmark studies finally established the cause and effect relationship of microbiology. In my opinion, are the study of a non-specific plaque hypothesis, Walter Loesch, 1965 study of Harold Lowe, which established the cause and effect relationship of plaque and gingivitis. And the third is the specific plaque hypothesis given by the Sokransky. So these 3 studies over a period of last 100 years established one paramount fact, that periodontal microbiology is the research to do in case we are looking to eradicate or to contain en masse the periodontal disease. Now, yesterday when we were sitting in the these presentations by the PG, I was with Colonel Prashant. Sir was also there. Out of 10 presentations, 8 were somehow related to microbiology. Whether it was, a mouthwash, the role of a mouthwash, again on certain, microorganisms and other, but 80% of them were basically related. So that shows how popular the periodontal microbiological studies are to the research. Now, this is one aspect of it. The second is, having said that it is a very popular avenue, what are the difficulties which are associated with it? Basically, we all understand that mouth is having so much, taxonomic variation that to obtain a representative sample of a particular microorganism which we are, trying to find, is finding like a needle in a haystack. It is so difficult. So because till a few years ago, we were limited only to the cultures. At best, we were only doing cultures, and so many bacteria, microorganisms, or other, microflora would remain away from the purview of cultures. So that was one difficulty. Now that was solved by, as we came into PCR, immunoassays, DNA related, DNA probes, all those things, and advancement, cloning, all those advancements occur. But despite these advancements, 3 or 4 fundamental problems which are associated with the periodontal microbiology remain. One is to obtain a representative sample. Number 2, the variation of taxonomy. Number 3 was, we do not know what active sites are. It is very difficult to find out what are the active sites. So, and the 4th was contamination. Always, whether you are planning something, some amount of contamination while collecting the sample remains inevitable. So there's a procedural problem which is there with the periodontal microbiology. Of course, over the period of time, we'll see how we have been able to solve all that. But when you plan a periodontal microbiology related study, you will have to keep all those 3 or 4 factors, because you will be the one who would have to be ultimately answering the queries. Because it is very easy to say, I obtained this and I got this and culture said this. But to be absolutely, certain about the entire process, it would be very, very, prudent on your part to think of your study very, very judiciously before you delve into periodontal microbiology, because it should not be like a fashion statement. Everybody is doing it, so I must also do it. That will not serve the purpose. So, sir, in my opinion, these 3-4 key points have to be kept in mind before you even start on a periodontal microbiology study.
Very rightly said, sir. I totally agree with you. So considering that the microbiology associated with periodontal pathologies is quite complex, quite interactive, we still have limited knowledge about many causative agents. With the newer technologies coming in, with the newer research methods coming in, we have made quite a bit of progress, but still we are far away. Here and there, you keep on hearing about various other things being the ecological agents, microbes being the ecological agents. So as sir rightly said, it should not be just a fashion statement that we are following what others are doing. As one of the characteristics of the studies being that it should have value and we should fill in the evidence gap. So sir's point is very valid in to see that whatever we do, we should fill up the evidence gap which has been left by the previous studies. So considering that another discipline in periodontology is coming up very well due to the newer researches in technology which has happened, biomarkers assessment has become quite an essential tool to see what are the changes which are happening in the periodontal tissues, what are the markers which are responsible for that. So I would like to request Dr. Anil sir to please shed some light on the factors to be kept in mind while planning a study on biomarkers.
Thank you, Vikram. Esteemed panelists and dear students. First of all, I would like to request all the postgraduate students, because you're doing one research project, that's thesis, right? Never compromise on that, because it's a one-time study what you're doing. And the sad part is, the first 6 months you have to finish the synopsis. So probably you're not aware how to go about whether it's an important topic. And we see that many times halfway through, probably you cannot get the criteria done. So it's important to evaluate on all these aspects what we have talked about. And biomarkers, basically, we are, it's important because we get the staging and grading of periodontitis in many stages. So it actually, the data what you get in my biomarker research is, it identifies the risk factors, unknown link with systemic diseases, and also your therapeutic response. So when you talk about the source of biomarkers, basically it's three. One is inflammatory mediators, second is tissue destructive mediators, and third is bone remodeling mediators. So these are the various sources. When you talk about inflammatory mediators, you have interleukin-1 beta, interleukin-6, 8, and 10. While in case of tissue destructive, you have MMP 8, 10, and 13. Same with bone remodeling, you have mediators, you have osteonectin, OPG, etc. So these are all various sources for a biomarker. And it is key because at every stage of the disease, you get an accurate data because you get a biomedical data as such. When you talk about the sample size, all the literature says that you need a bigger and larger sample size when you do a biomarker study. In vitro and in vivo study is also possible, and many literatures, it's a randomized clinical trials which has been done, specifically targeting the particular biomarker. So even nowadays, we see that biomarkers are used in peri-implantitis cases as well as in retrograde cases, where to understand the staging and grading of periodontitis, which is also an important parameter in the maintenance phase as such. So this is one area what I want to highlight, summarizing that in vitro and in vivo study as well as a larger sample size, and the sources normally for the biomarkers to start the study is basically from three: inflammatory mediators, tissue destructive mediators, and bone remodeling mediators.
Thank you, sir. Thank you for the insight into the planning of studies with biomarkers. So we should take into account the source of the biomarkers and decide on the assessment methods accordingly. Now coming to the much popular topic of the present times, the implants. So implant-related research has also become quite an integral part of periodontology. It is a much sought after field by all the specialities. They try to claim theirs, but we all know it rightly belongs to us. So a lot of research is being carried out on implant-related topics. Lots of materials have come up. There are changes in implant designs. The response of the tissues has to be evaluated, which nobody can do except our specialty. So considering this, I would like to put a question to Dr. Kolte, sir. So what are the nuances of planning a study on implant research, sir?
Vikram, probably and presumably, we are talking about the research with regards to postgraduate students.
Yes, sir.
So when a postgraduate student enters into the post-graduation, he is left in an ocean wherein he has to, within the first few months, go in to select a dissertation topic.
And if you go by the choices of postgraduate students, anybody and everybody would be wanting to have a clinical topic, maybe related to perio, maybe related to implants. When it comes to implant topic related to implant therapy, many postgraduate students and even many of the postgraduate teachers would have a mental block. Just to quote you with an example, we in our department, I myself had a mental block with regards to research related to implants. Because of the fact that when you go into a clinical implant topic, having an observation period maybe of a minimum of 6 months post insertion would be difficult many a times. To get so many patients, to have so much expenses on the topic, and then to follow up the patient. Even the patient needs to be motivated for a continuous and a regular follow-up. But then I would tell you that mental block went away within the last 5 years when we started giving our postgraduate students with topics related to implants. But the first criteria should be the student himself or herself should be interested into working on implant research. The second query which comes to one's mind is why a particular aspect of implant therapy needs to be evaluated, needs to be assessed. And there could be multiple reasons. There could be a new design of implant which has come into the market, which needs to be evaluated or which needs to be compared with the previous designs. This could be one of the aspects. The second aspect could be with regards to loading protocol in implant therapy. It could be immediate loading or immediate implant followed by immediate loading or immediate implant followed by delayed loading. So all these things needs to be evaluated. And mind you, at no point of time we think that it should be a landmark research. The only criteria which is required to be decided by the student is what is difference between the available literature and what the student is going to do as far as the research evaluation in implant therapy is concerned. Now there has to be some novelty. Majorly all the research, most of the research I would say 99% of the research would be a substantiative type of research. They would substantiate the earlier findings. But at the same time, there should be some novelty associated with this substantiation, and this novelty could be in terms of an additional parameter which could be evaluated. Now, say for example, when you go and choose a topic of implant, there could be different study designs in which one can go into and work. And as far as the literature goes, randomized control trials are best as far as the evidence is concerned, and most of you would be wanting to go in for a randomized control trial. The various methods you would be aware, the methods remain the same, whether it is a clinical topic, whether a topic related to implant therapy. So randomization process needs to be strictly adhered to when one is going into a clinical or an implant related topic. Then comes the aspect of sample size. Again, sample size would be an important aspect. And when we consider, say for example, one is going to evaluate the success of implant therapy in smokers, and your sample size comes to 4 or say 5 patients. But in that, even though statistically it might be significant, but that is not relevant, because if your sample size has 50% of the patients who are smokers, then there could be a chance, if you go by a randomization through a lottery system, there could be a chance that all the smokers would fall into one of the categories, and then your assessment would be biased. So in such a case, having a sample size which goes towards infinity, I'm not talking you take infinite number of patients, but then which increases the number of patients as your sample size, it would limit the amount of bias. The third aspect of improving research as far as implants therapy is concerned is with regards to blinding of the observer, blinding of the clinician, and even the calibration, as has been rightly said by Dr. Anirban. So calibration before the commencement of the study, it could be a pilot study or it could be the first initial few measurements which can be utilized for calibration of the observer and clinician. It is always better to have different individuals doing the job. And once you work on these modalities, one more additional question which comes is, what is the way which you are going to follow the protocol? You need to formulate a detailed protocol. Each and every step should be enlisted when you start with your exercise. It should not happen that you go on haphazardly, you place the implant, you do not do preoperative evaluation, you do not do the inclusion, you do not consider the inclusion or exclusion criteria, and suddenly later on you recollect that, oh, this patient should have been excluded. And this patient is suffering from a systemic condition, and I have included him or her into the study sample size. So it is always better to have a systematic recording of all the inclusion and exclusion criteria. It is always better to go in a systematic way, and it is always advisable to have a detailed case history pro forma right at the time of submission of your synopsis. The moment you have a written pro forma, clinical pro forma for each of the patient, that moment onwards, you are very methodical, you become very systematic in recording of all the parameters, because preoperative parameters would be recorded first before the starting of the patient, after placement of implant, maybe after 1 month or 3 months or 6 months or 9 months, and the radiographic evaluation which is associated with implant therapeutics, and which is so very important, because radiographic parameters also, there would be different radiographic parameters which can be compared. So there are so many studies, there is so much literature with regards to implants, but still many clinicians would want to venture into implant research. One more new aspect which is coming into picture nowadays of late in the last few years, which we have observed, is patient-reported outcome measures. So more and more stress is being laid on what the patient feels about the treatment, whether it is before treatment, whether it is after treatment, that is pre and post. It could also be patient-reported outcome measures by different techniques. And this is an important aspect which needs to be judged by the evaluated and assessed by the clinician after before planning of the implant research. And I would want to add an interesting aspect with regards to implants is we are just going into practicing implant therapy. There are major differences between a natural tooth and implants. You cannot always go and do whatever has been tried into a natural teeth and say that this would be definitely effective in implants. No, that is a big no, because it has been preliminary reports have assessed many aspects of implant therapeutics, and it has been shown, it has been reported in the literature that implants differ from a natural tooth. It could differ in terms of the inflammation, management of inflammation around the implants, or it could be with regards to treatments which can be occurred and complications. So one needs to decide why such an exercise has to be adopted into a particular patient. So I think these are some of the important aspects which needs to be considered by the clinician who is going to do the implant research.
Thank you, sir. So all of you must have just seen how important it is, the planning part of the study, how do the planning in a very systematic manner. We can take guidance from previous systematic reviews and meta-analysis to see what kind of parameters, the sample size, the sample, what we want. So all these are very important part. So now once the planning of the studies have been done, we come to the next step of executing. How do we execute the study? So for this, I would like to put the question again to Dr. Anirban sir. So please inform us about the various, inform us about how to conduct clinical trials.
Thank you, Vikram. So as we are, all of us, all the panelists have discussed how we are, now that you have started the dissertation per se. And one thing has to be made sure that whatever is there in your synopsis, whatever, like as Abhay also told, exclusion, inclusion, everything should be taken into consideration. So after you have started, it depends on how many groups you have taken. So more the number of groups, it will muddle, the data will muddle. So it's preferably 2 or maximum 3. More than that, if you take subgroups of more than 3, then it gives rise to more of false positive. Although there is no difference to reach whether that is a false positive or a false negative, more groups will have substantial confounding error, and the research is said to be invalid because we'll have a data muddling. Now, whenever the result is coming, again, once you have started and eventually you have taken, as I told you in the earlier study, the power of 95, there are 15 in each sites. That means 3 groups you have taken. Automatically, there is 45 sites. Okay, individual sites, like you have taken the measurement. Now, you cannot reduce the number of sites in each group. The patient has not come, it's not the case. You can do more number of cases, like 17 in each site, each group, but you cannot go to one particular site. Is there, you have got one group, only 14 instead of 15, which is the what you have already done. That will definitely give you a negative result. See, negative result is nothing to be worried about. My result has come negative. It's okay. If you have followed all the criterias and meticulously followed everything what was told or what was before starting, then negative result also comes. You have to justify why there is negative result. Okay. And as I told you, the calibration, at least 2 people should have the calibration. Now, 2 people in the sense, as I told you earlier also, gold standard is your guide. When you're measuring a pocket, if there is a difference of about, say, kappa statistics, that is what is taken into being, kappa statistics, 0.08, if there is a more than, if it is 0.08, it's good. 0.9, between the 2, your guide and yourself, when you're measuring the pocket depth, 0.9, excellent. But if it is below 0.7, kappa statistics, what we call it as, that means you have to again learn how to take the measurement, the pocket depth. That is one example I'm just giving. So it should be done in a different state. The guide will not tell you what is the measurement, and eventually you need to tell what it is. Then you do the kappa statistics, and then you come to the differences. If there is less than 0.7 or less than 0.8, that means you need to repeat again. That means you need to learn again. If there are 3-4 cases, you saw there is a difference of less than 0.7, that means you need to repeat. You need to learn again. So this gives you a negative result. So you should be able to do this. Then whenever the result comes, we give more importance to p-value. To p-value is more than p-value. It is CI, confidential interval, that should be given into consideration. Whenever it is, it should be given CI, confidential interval is more important than p-value nowadays. So those things needs to be taken care whenever you're giving. See, the question is, the result has come negative. Change it, make it positive. That means you're playing with the results. You're playing with the, that means you are not, your dissertation, whatever you've written is not correct. Let it be negative. Let the result be negative. Doesn't matter. But you have to justify why it is negative. If you follow all the protocols and whatever you have written, whatever you have taken, the number of patients, number of subjects, number of sites, whatever it is, then definitely the result will be positive. If it is negative, even after that, nothing to be worried. Nothing to be worried. If you have taken every protocol. Now, this protocol, if it is not done, like I told you, at confounding thing like the gold standard guide, and you have not taken the measurement properly, pre-intervention and post-intervention, then it can come a negative result. Okay, that's what happens then. Then you change it. You try to play with the data to make it positive. Obviously, that is not going to happen. Okay, so this is what needs to be taken into consideration in a clinical trials.
Right, sir. So, Dr. Subhash, sir, so considering that periosystemic interrelationship involves us getting data from other fields of medicine too, and considering that we may not get all the data from a center, can you guide us about execution of the studies with regard to periosystemic, whether it should be multi-center, how to collect the data, how to analyze? What is the best way to know about the actual interrelationship between periodontology and other fields?
Yeah, as I planned in a way that what should be my research question and what should be my hypothesis.
Yes.
As I understood, if I want to do a good dissertation on periosystemic, obviously I will definitely go for a clinical trial. I mean, a randomized control trial, because as the literature says, the causality between let it be periodontitis and diabetes or cardiovascular disease or adverse pregnancy outcomes, all the RCTs has given inconsistent results. So now when I plan my material and method, I have to think what was the lacunae in all these randomized control trials that they got inconsistent results. So the major drawback in randomized control trial, if you look at all the studies in periodontology, hardly there is any randomized control trial that has measured the primary outcome of the study. There is no randomized control trial in periodontology that has measured the primary outcome. Okay, so primary outcome means in periodontology, the primary outcome is either the tooth loss or it is peri-implantitis or a loss of implant or failure of implant. So no RCT has that primary outcome.
Absolutely.
And when we talk about randomized control trial, all randomized control trials are lacking in external validity.
Yes.
Because of the sample size, because they don't have the primary outcome, there is no clinically relevant outcomes. They always take surrogate outcomes. What I mean by clinically relevant outcome means these are the primary outcomes, either tooth loss or implant loss. But when we talk about, because nobody has taken that clinically relevant outcomes, all has taken surrogate outcomes, like let it be the biomarkers, let it be the radiographic parameters, or let it be any parameters, CAL or PPD or whatever. So these are all surrogate outcomes, because periosystemic link cannot be established on the basis of surrogate outcomes.
Right.
So we have to think, if we have to plan for a RCT with a causation, cause and effect, we have to plan in a way that it should be a long-term study and we have to take the primary outcome. So it may not be that easy, but if I think of planning a randomized control trial in periosystemic disease, then I have to look for this primary outcome. And another major drawback is the case definition of periodontitis. So whatever the studies done on periosystemic, these are all the case definition of European Federation of Periodontics or the American Association of Periodontology, and these case definitions varies. So all these studies, somebody has taken one case definition, another study, another case definition. But at least now, as Dr. Ashish was morning telling, the 2017, I think for intervention trial, we can take the case definition of 2017 classification periodontitis. So if I plan for any randomized control trial on periosystemic disease, definitely I will take the case definition of 2017 classification, and I will plan with primary outcome. Or now the solution is, as a postgraduate student, because they have to do the single centric study. So for them, it may not be valid. But if I do a periosystemic study intervention trial, then obviously it should be multicentric trial. And very important is the core outcome setup, because every specialty needs a core outcome setup. Like instead of this primary outcome, we can set a core outcome setup, taking into consideration of all the stakeholders. Like let it be the patient, let it the funder, let it the researcher. So all sit together and have a primary outcome setup. So that is in, I think in European countries, they have already started in outcome setup. So we need a primary outcome setup. And we have to think of multi-center trial, because the major problem with RCT is the sample size and the external validity. So in that way, we can take a good number of samples, and we can have a very good effect size in multi-center trials. And even we can do remote randomization in multicentric trials. So randomization is also not a problem. So in that way, if we can do this, then definitely, because the cause-effect relationship is not at all established, so we can plan for. That is what, as ISP is planning a study on periosystemic, so we can look for all this, the outcome setup and the multicentric trials.
Absolutely right, sir. So I do agree with sir. And as he said rightly, the ISP is now going towards promoting periosystemic studies, and that also the multi-center studies. And so as a postgraduate, we may not be able to do a multi-centric study, as sir said. We would be able to concentrate on one type. But then as a society, definitely it's possible to go for multi-centric studies and get more data with regards to. Coming to the topic of periodontal microbiology, sir. So it is a very complex field. We have so many variations. So many difficulties, practical difficulties are also there with regard to procurement, storage, transportation, plus data obtaining. And we do still have a limited knowledge in the field. We know there's a vast scope, vast amount of knowledge. Sir. And how would we execute a study on periodontal microbiology?
See, basically, from all the discussion, the most important buzzword has been the evidence. You know, everything is now based on evidence. So what is the primary aim or objective of doing a study? As a postgraduate, our ultimate aim remains that it should be published in a good journal. So whatever execution of our study we plan to do, it has to be in a manner that ultimately it is accepted in a good journal. And today, after so much research has been done on AA, PG, and Tenorella Forsythia, these are the three most, flogged horses of, if I may say that, much flogged horses of microbiology. So even bacteria, these microorganisms, what are guidelines which we need to follow so that we obtain a good research publication. And these days, because of evidence, whatever studies Subhash sir has talked so much about systematic trials. All these systematic trials or RCTs follow a set of guidelines in case we wish to publish them in a good journal. And these specific set of guidelines are known as the PRISMA guidelines or the consort guidelines. There are more, of course, but let us confine ourselves to these two, the PRISMA and consort. Consort means the consolidated standards of reporting trials. It is a set of guidelines which came into being in 2010, having 25, a minimum set of 25 items which you have to refer in case you want to have a good publication. It should be true on the consort guidelines. And similarly, for RCTs and meta-analysis, you have PRISMA guidelines. PRISMA are the preferred research items for systematic studies and meta-analysis. So PRISMA is a set of 27 items. It came up in 2009. Consort came up in 2010 with a set of minimum 25 items. So until and unless your studies, howsoever complex they may be, stand true on these guidelines, it will be very difficult to publish them, because the best 400 journals, they all see whether you are following these guidelines or not. Now, what are these items? What are these set of items? These items actually start from your title, abstract, your introduction, material methods, results, discussion, funding, everything. All these items need to be included, one. And two, they follow certain flow diagrams. Flow diagrams is what is the process of screening, what is the process of distribution, what is the process of analysis of those items. So there are clear-cut guidelines which you can even have, download from the internet also, and they are available in good journals also. Different sites are there. Similarly, for observational studies, since we do a lot of epidemiological studies, there's another set of guidelines called MOOSE, MOOSE, which is for observational studies in epidemiology. Then for case reports, you have CARE, you have STROBE guidelines, you have START guidelines. So many guidelines are there. So see what type of studies you are performing, one, and then are you true to these evidence-based guidelines? Because until and unless you follow them scrupulously, what is the aim of these guidelines? These are evidence-based guidelines. The very aim is to raise the transparency standards in research. The key word is transparency. So if you follow that, that means you've done a transparent research. So idea is not to have a positive or a negative outcome. Idea is to have a transparent research and to check whether these interventional studies which you have done, health interventional studies, whether they are actually good or bad for the final, outcome, which is your patient. So in short, I've tried to explain what you for designing your studies, go through these, follow these, and then probably, start writing for your paper. Thank you.
Yes, I agree. There might be, this might be one of the major lacunae why the studies don't get published, because they're not following the correct guidelines. And as has been the evidence-based approach, following the correct guidelines is very important. Then only your study gets shortlisted for systematic reviews, and then only it gets its valid value. Coming to the studies on biomarkers assessments, so can Dr. Anil sir, can you please
First of all, thank you for sitting too late. Very few are here. You are our original researchers, I think. Okay, thank you. 15 of them are there. Okay, now execution in biomarkers normally. Yes. So study execution now for the biomarkers. Normally the samples are collected from GCF, saliva, subgingival plaque. So now when you divide this class of biomarkers, we divide into as predictive biomarkers in a healthy individual, prognostic biomarkers, and diagnostic markers. So in case of this diagnostic markers and prognostic biomarkers, we assess the staging and grading in different stages. So when you divide these biomarkers, we know that there is a static and dynamic, and under static you have genetic as well as histopathological, and under dynamic you have immunological and microbiological. Now, various chairside kits are available. For example, when you take about the microbiological, the sample collected is from the subgingival plaque. And we have kits like Evalucyte, we have kits like Bana enzymatic kit, MyPeriopath. All these kits are available for assessment. And in case of biochemical, we have the samples taken from the GCF, and we have kits available such as Pocket Watch, Periocard, etc. So in case of genetic, we have the samples taken from the cheek as per a swab, and also as why we are doing this? Because we have an accuracy of disease progression. They say that it's smart. The biomarker, the predictive kit, what you're getting, the chairside kit, it should be smart. That is specific, measurable, achievable, reliable, and now we have a lot of literature studies are going on with micro nano sensors attached to mouth guard or attached to the teeth itself. And these nano sensors will give the value difference when there is a disease activity. Now we are going to the area where it's called as a point of contact test, because the patient, the chairside, we should be evaluate the chairside itself, and we should come to well that disease staging in the incidence, like how to do a diabetic check. So these are all various advanced diagnostic aids and the sampling what we do in case of biomarker. So this is a data what you get, and this data we will compare these three categories, that is diagnostic imperative, which give you a correct early and staging of periodontitis. This is the way you can.
Right. Thank you, sir. And finally, to Dr. Plan-related, what kind of meters or kind of tools are important for execution, and what your views? What should be kept in mind like executing a study?
Just before to speak of your, I want to bring to the note those who are present here, not related to implant therapy or implant, but overall research in dentistry. Now, there are interesting statistics with regards to the number of 2012. Now, the number of years of the dental profession is the kind of evidence which has been generated was not appropriate. Most of it is not appropriate, and so whenever we are doing a dissertation, whenever we are doing a clinical exercise or a biochemical exercise, one needs to stick to the point that we and concentrate on the quality of work we do. We may do a little less work, but then the work should be qualitative in nature rather than being a quantitative in nature. And the other interesting aspect with regard to publications is we are moving in research, clinical research. This has been observed over 10 years period of observation. wherein the impact factor of journals such as Journal of Dental Research has not increased to that level as compared to Journal of Clinical Periodontology. If you observe the impact factor of Journal of Clinical Periodontology, it has increased substantially over the last 10 years as compared to the basic research journal of Dental Research. So these are some of the interesting statistics which I thought would be important for all of you, and the way we work on our research dissertations. Now, when it comes to implant research, or for that matter, any of the research, one needs to be very specific about the case definition of the pathology which we are evaluating or going to assess. Because case definitions have been different. For many terminologies, the case definitions are different. Say, for example, if you go to an article which was published in Period 2000 by Cochard, the case definitions of peri-implantitis, it was 4 millimeters of probing depth and 6 millimeters of probing depth. These were two different case definitions given, two different parameters which were given in two different case definitions. And along with the probing depth, it was the radiographic bone loss, which was 2 millimeters and 4 millimeters. So if one wanted to diagnose a peri-implantitis according to the first case definition, it could be a moderate peri-implantitis with 4 millimeters of probing depth and 2 millimeters of radiographic bone loss, or it could be severe if it is 4 millimeters of probing depth and 4 millimeters of radiographic bone loss. While according to the second definition, it was 6 millimeters of probing depth and 2 and 4 millimeters of radiographic bone loss. So two different case definitions, but yielding 4 different cases which can be identified or which can be diagnosed by the clinician. So whenever we are venturing into any of the research projects, one needs to be very specific about what is the case definition of the pathology which one is going to study or examine. One more, the other day we were working on a systematic review, and one of my postgraduate students had brought in the case definition, the measurements, the parametric measurements of clinical attachment levels, measurement of clinical attachment levels. And there was one article wherein the clinical attachment levels were measured from the base of the stent, whereas regularly we go into measure clinical attachment levels from the cement to enamel junction. So these are different aspects which can vary according to the author, and one needs to be very specific about what we are going to record and what we are going to examine into our patient. So these are two important aspects, and most of the authors have covered many aspects of methodology. So I would want to sum up over here that rather than concentrating more on qualitative research, let us do quantitative research, let us do qualitative research, so that the evidence which is generated out of it is really beneficial for the human race. Thank you.
Thank you, sir. So very rightly said, sir. So now that we are aware about the planning, we are aware about the executing, to some extent about the reporting, but as postgraduates, the most important question for us as part of our partial fulfillment for the degree of MDS is presenting or reporting our results, right? So for this, I would like to ask Dr. Subhash, so please enlighten us on how is for these, and what are the major issues and solutions which you can guide us on.
Actually, if we don't have to be any problem with reporting, the first of all is there should be a good pilot study where you know your lacunae, what you want to improve when you exactly do the study, and what data was missing in pilot study so that you can include it. So pilot study is very important. And as Grover sir was telling, you have to follow reporting guideline as per the study design. So you can go to Equator Network. All the guidelines are there for all types of studies. So that can be done. And as a postgraduate student, while writing the results, 2-3 points I'll just tell. Like it should be in past tense, number one. And you should not, you should use active voice instead of passive voice. That means if I'll give an example, the systematic review on PRF was carried out by Dr. Anirban Chatterjee. So this is a passive voice. So I have to write like this: Anirban Chatterjee carried out the systematic review on PRF. So in that way, the results should be written. And the next one is you should use verbal phrase rather than long nouns. Like as the figure 1 shows, the periodontitis increase, a significant increase the level of interleukin 1. So this is a long noun. So I have to write as the figure 1 shows, interleukin 1 level increased in periodontitis. So this is during the results, like the writing pattern should be like this. And at the beginning, the results should have an introduction and the context in brief. And then tabulated the demographics, all these material methods after the introduction, then all the parameters that you have taken, and it should be discussed.
That's right, sir. So very rightly said, sir. We should be using an active voice while writing our thesis. That's very important, and it will make life much easier for the guides too. And we are all quite aware about the various aspects of how it is categorized, like your introduction, material methods, results, your review of valid review of literatures, which should have quite a bit of systematic reviews. It increases the validity or the value. Now, the last word I would like to have from Dr. Anirban sir. So would you like to add some points, like a lot of discussion has already happened with regard to reporting and all. Would you like to add some more points we should be considering for publications of the research?
Okay, everything, I think Abhay and Grover sir has already mentioned, even our son Subhash has already mentioned regarding the publication. So the main aim for whatever you're doing, end result should be a publication. It should be, because the work what you have done, dissertation, is definitely unique, because it is, everybody's dissertation is unique. Somewhere there is a difference. What you cannot copy pasting unless you're copy pasting from some other dissertation and doing it it is done in Lucknow, and at somewhere down means up north or up down, copy paste. That is different. Taken all the criteria spoken by all of us has been taken, and it needs to publication. We have our editor here, so I don't want to take much of the thing. See, research, whatever you're doing, needs to new scientific methodology should be followed. So writing in particular the science is a great art. You should be properly written. Whenever you're doing the dissertation, it should be in your mind that this particular dissertation will get publication. Now, what happens? You get rejected the moment you send to any journal, a good journal. Okay, as per yourself, it is the best thing you have done, the work, but it gets rejected. Now, it doesn't mean that you have not done a good work. Might be the way you have written is not correct. You have to check a lot of things in that. So the statistical analysis, if it is done properly or not. Because if again you have played with the statistical analysis in the result to bring it positive result and all, it can be found out. And as I told you, our language skills should be better. The grammar, the punctuation, then unconventional writing, that should be properly done. Now, for example, I'll tell you, I have almost say 26 or 27 papers on platelet concentrates. Out of that, there are case reports and this, that, and that. Out of that might be research is 18. Out of 18 research, only 4 are included in systemic reviews. Only 4 of them out of 18. Now, I always think, why only 4 of them have been included in the systemic review? Why not all the 18 of them? There is criteria in systemic review also. There are a lot of criteria which they take into. It's not that my study has been bad or my study has been flawed or something like that. Now, but there is the thing, when they take the systemic review, they have certain points. Okay. Now, one systemic review accepts only if the sample size is more than 100, more than 90. Okay. They have the criteria. The moment it becomes, see, if I take 15, 45, automatically it's cut. It's not more than 90 or 100, obviously. So that doesn't include in the systemic. Some systemic review says the dropout number should be less than 10%. Now, if you have a dropout percentage more than 15 in dropout, automatically that criteria are removed from the systemic review. So then sampling design should be clearly written. How many arms? In this arms means they take how many groups you are having. Again, more than 4 groups means, more than 3 groups means they don't take it because its data will be flogged. Okay. Then calibration of examiners, how much intervariable examination is done. Okay. So those are the things that is taken. It's not that your study is flawed or why it is not coming, because might be it is not in the under that criteria. Okay. But don't get disheartened that it is not published in this journal, that JOP, JCP, example. I'm just telling we have such a wonderful journal. Just a lot of people, they directly go to JOP. They directly go to JCP. They go to periodontal research. Yes, I agree. But this is a wonderful internationally PubMed index journal. Why not give it there? Obviously, taking all the things into consideration. Writing is an art. Writing the science and putting it up is definitely an art. If you have done it in a proper way, there is no point that any editor or any journal will reject your work. Ultimate of your dissertation should be, it should get publication. Publication is the ultimate. That's what people will know, the amount of work, amount of effort you have done in that. Right? So I think that everybody has spoken. We have taken enough of time. So
very useful information that you have shared with us with regards to what all points to be kept in consideration for publications. I like the point about sir when he said like we fudge the statistical analysis and it can be found out. So to this, I might like to add a bit of word of advice. In cases our results are not coming up to the expected levels of what we thought it would be at the start of the study, I would like to tell the postgraduates to please don't fudge the results. The main reason being, even if something is not working, that is adding to the literature so that we come to know of what works, what doesn't work. So for future study, how to conduct the study, maybe in the right manner, if you're not being able to get the required results. So going ahead with this, I would like to throw the session open for the audience if they have any questions for our panelists. Yes, sir. Please, sir. Sir, for that.
Follow-up of after completion. Yeah, so that's what I told. No, you should take up the time span. They have 2 years, 6 months before submission, and 6 months. See, one synopsis 6 months, and 6 months before the exam, they have to submit. 2 years. Ideally, have a 9-month follow-up. Minimum 9 months should be the follow-up. minimum.
So
6
nine-
months,
9
3
months
months,
is-
not what is idle, 9 months minimum. If it is 1 year, it's wonderful.
Because the time to write, get it corrected, get it published.
They can do, write up his introduction, this, everything can be done. Review of literature, methodology, everything can be written and ready. Only the result has to come, and then the result and the discussion part, how much time it takes? You can finish it in 1 week's time. The write
same
up of the
question
result
to
and discussion.
Abhay
If
sir.
I'm wrong, I don't know.
Sir, the
What you
same
say?
question to Abhay sir, what about implant related clinical trials? What do you consider an ideal follow-up time period, sir?
There's no ideal follow-up period for any of the type of studies. The longer it is.
No,
the
considering
better
that
it
it's, we only have a time span of maybe 2 years, 2.5 years for a postgraduate student.
So it
to-
depends on the efficiency of the postgraduate student as well.
And the
Because if
sample-
the
obtaining the
PG student is determined to complete the given sample size in a very specified initial period, then he may very well go on to have an observation period of 1 year as well. So it depends on the number of patients attending the hospital, the number of patients available with those kind of case definitions, and the determination of the postgraduate student.
So my next question is for Dr. Subhash sir. So you talked about primary outcomes and surrogate outcomes. What about quality of life studies, QOL studies, sir? Would you consider them as primary outcome?
Which one?
QOL, quality of life studies.
That is also considered as the clinically relevant outcome. That is from the patient side.
Yes, sir.
Because clinically relevant outcomes are two, either subjective or objective. Okay, so the clinician that we as a researcher, what we see, that is the tooth loss or implant loss. So that is the objective. But from the patient side, like how the patient feels, pain, anxiety, this QOL, all these are clinically relevant outcomes or the primary outcomes, the objective outcomes, that is patient based.
I'd just like to add one point to Dr. Grover sir's. You were talking about the periodontal microbiological studies, sir. In my point of view, the need of the hour for any periodontal microbiology study is good computer and internet skills. Considering that we have the human oral microbiome library now available for download and comparing, we can type or even subtype any organism up to 2000 plus microorganisms are available in the library. So it's almost like the Human Genome Project, and we now have the Human Oral Microbiome Project. So if you have a good computer skills, if you know proteomics, a bit of proteomics and genomics, our job has become far easier when we are doing what I feel.
Sir, we are talking of research, actually expect a postgraduate mix, whether it is metabolomics or whether it is proteomics in the limited time span they have would be, expected too much. It will be unfair for them. If it is purely a PhD or a researcher who's making a career out of the entire, research, for him, yes, definitely, why not?
Thank you, sir. I also like to congratulate Dr. Abhay sir for a very emphatic statement. He said it's not a job as a postgraduate student to make any difference. You are just adding incrementally to the knowledge. You are not going to do any paradigm shifting research. So as long as you keep that in mind, I think you will be fine and you will be able to complete your thesis within your postgraduate period. Thank you.
So
No research is complete. So anyhow,
But the student is not a permanent student, sir. He is out of the college at the end of his third year period.
considering
at
that
the end, the postgraduate will write, the long-term follow-up is required.
So it becomes a job of the guide. Student will do the research, we'll do the follow-up.
So considering that the MDS is a time-bound kind of period where research is done, definitely it can be taken up by the respective departments for further postgraduates to follow.
And adding on to Ganesh,
Yes, sir.
thank you for your valuable input. And research depends on guide, place of your institution, and a lot of factors, because a lot of limitations are there in many places. In Chennai, you can do everything, but in remote places like where we are, there are limitations because that is what is happening with it. So that is what the point what Abhay sir has put. It
I
is
completely agree,
yeah,
sir. Thank you, sir.
Thank you.
Thank you, sir. Thank you for the questions. So I hope it has been a very productive. Yes, ma'am, please. One last question.
Sir, actually, I would like to ask if we do a case in the institution, we take the ethical board approval from the committee. But if a case is done at a private clinic, how we have to take the approval for to get the article, the work we have done in published? How to get the ethical board approval?
You mean to how to get ethical clearance, something research?
We have
Yeah.
done a case report in
There
private
there
clinic.
are certain no case report you don't require. Nothing ethical approval is only for the research you require. Research.
Uh, Sir, I have already submitted an article in Clinical Advances of Odontology, the manuscript. It was a case report which was done at a private clinic, but they have asked for the ethical board
It depends on the
number,
nature
and
of
so
the case
I was
report.
confused. Any local body to approach to? Yes, sir.
Clinical trials now they are asking.
Now they are asking because in the case report in clearance.
They have a designated board of ethical committee. You can like if there in the college is there. If the college is near your clinic or something, you can ask them. But they have a sitting fee. Sitting fee they pay.
Madam,
They have a
yeah. For example, we had a similar this thing, one clinical practitioner regarding implant, he had done one this. So he has approached us and the institutional ethical committee has done the clearance for that and there is a sitting fee for that. So that is over. Yeah.
And sir,
Because this institutional ethical committee will be registered already. So once it is registered, there is a value for that.
So if the case has already been done and somebody wants to publish it in a private practice, so how then also the ethical board approval can be taken? That is only previously we have
Prior,
to
before
apply and
starting the
then
study,
only-
before starting the study.
Okay.
So,
Otherwise, you have to know the institution and ethical committee properly, then they'll give you.
thank you all. So if
He
you have
just-
any
he
further
just left.
queries, if you have any further queries, we can take it at the backstage. So if you have any further
Thank you.
queries, we can take it at the backstage. All the speakers are available there, the panelists are available there. So I hope this has been a productive session for the postgraduates as well as our colleagues who are here. It just shed some more light or clarity into how the research should be planned, executed, and reported. With this, I would like to present a vote of thanks to our esteemed panelists, Dr. Anirban sir, Dr. Abhi Kolte sir, Dr. Grover sir, Dr. Anil sir, and Dr. Subhash Raj sir, for enlightening the audience with their insightful thoughts and clearing quite a few things we should be aware of during the process of thesis writing. I would also like to make a special mention of my dear friend, Dr. Vishaka Grover, who has been very helpful to all of us in organizing this panel discussion. So she was the brains behind how to go about it and the sequencing. So really well done. Thank you, Doctor. So thank you all. Thank you for your patient listening.
Thank you all the panelists for giving such informative discussion. Now I would like to call upon stage Dr. Ganesh Puttu sir to felicitate Dr. Anirban Chatterjee, Dr. Abhay Kolte sir, and Dr. Anil Mehta sir.
I would like to thank Vikram for wonderfully conducting this panel discussion with patience. So I think he needs more a loud of applause than us. Thank you, Vikram, for doing a wonderful job of moderating this program.
I would also like to call Dr. Surinder Sachdeva sir to felicitate Dr. H.S. Grover sir, Dr. Subhash Chandra Raj sir, Dr. Vikram Balagna sir.
Okay, yes. So thank you, everyone. So we are done with the second day of the convention. Thank you, everyone. Thank you so much for so silent hearing and for all the kind attention you all have paid. We would like to inform you all that you all are invited to the banquet night today at 7:30 p.m. And for all those who need convenience, for buses are available, which will leave at 6:30 p.m. from Law Auditorium. So we hope to see you all soon tomorrow morning at 9 a.m. with the breakfast. So thank you, everyone. Thanks a lot.